Good evening, Ji. Good evening, everyone. This is Dr. Nitin Bhagat. I'm a surgeon by education. Now, see here. First, we'll start with the basic anatomy, right? So, whatever you see on your screens, the blue-colored bone, like blue shaded bones, so they are a part of the axial skeleton. Axial skeleton. How many bones are there? Around 80 bones. And which bones are included? Ossicles are included in the axial skeleton. Hyoid bone is included in the axial skeleton. So the word axial means axis. So these bones are present at the center, of the body. And what is their job? Protection of the internal organ, like ribs, they protect lungs, ribs, they protect spleen, ribs, they protect liver, right? Now, the appendicular skeleton, 126 bones. The pink shaded bones. What is the function? The function is locomotion. The function is locomotion. See here. You see, it is already written, right? We don't have to waste time. So, axial skeleton, 80 bone, appendicular skeleton, 126 bones. So, this includes the hyoid bone. This includes the ear ossicle, appendicular skeleton. This includes the clavicle. So these are like PYQs which have been asked, that which bones are a part of which skeleton, right? Now, what is the use of axial skeleton? Weight bearing and protection. Protection of internal organ. Protection of internal organs. Right? And appendicular skeleton is primarily used for locomotion, right? Now, what are the diseases which are common at the axial skeleton? Tuberculosis. Remember, tuberculosis, T11, T12 and L1 vertebra, center of the body. Fine. What are the diseases which are common? Fractures in osteoporosis. Right? What are the diseases which are common in axial skeleton? Right? Tumors, bone tumors, they are common. Bone tumors, they are common in the axial skeleton, right? Appendicular skeleton. What are the diseases which are common? Osteomyelitis, right? Traumatic fractures. Remember, what is the most commonly fractured bone? Answer is clavicle. What is the most commonly fractured bone in children? So in children, the most commonly fractured bone is the forearm bone, or the forearm bones. Yes, 110% enough for FMG, right? Now, what are the different parts of the long bone? But before that, you see, the outer part of any bone is made up of compact bone. So cortical bone, also called as compact bone, it is very, very dense bone. Now, because it is dense, it has got poor vascularity. Now, cancellous bone is the inner part of the bone, and it is less dense. So this is cancellous, and the outer part is cortical. Okay. Now, part of the bone. So at the end, this, we have got epiphysis. In the middle, we have got diaphysis, and diaphysis is also called shaft, right? In between both of them, we have got metaphysis. So let's shift to the next page, right? Epiphysis is at the end. What is the disease which is common here? Disease which is common is osteoclastoma. What are the diseases which are common at the diaphysis? Fibrous dysplasia, Ewing sarcoma, osteoid osteoma. Real action lies at metaphysis. What are the diseases which are common? The The diseases which are common are osteomyelitis. Fine. Diseases which are common are osteochondroma. What is osteochondroma? It is considered most common benign bone tumor. Diseases which are common at metaphysis, osteosarcoma, that is most common primary malignant bone tumor, most common primary malignant bone tumor of osteogenic origin, right? That is about the most common. Right? Now, at metaphysis, what is special at metaphysis? At metaphysis, most of the bone is cancellous. You see, have a look at the bone structure. Now, here. So, this is epiphysis. In the center is the diaphysis. Now, in the diaphysis, the bone is like very dense. Here, bone is very, very dense. But in the metaphysis, bone is less dense. Fine. So, hence, malunion is a common complication of supracondylar fracture of humerus. Supracondylar fracture of humerus. Fracture ki jagah we will use the hash symbol. Fine. It is a common complication. So, Colles fracture. So, malunion is a common complication of extracapsular fracture of femur. So, all these fractures, what is common between them? इन तीनों में क्या common है जी? इन तीनों में common ये है कि सारे fracture कहाँ होते हैं? Metaphysis पे. All these fractures, they are common at metaphysis. Right? So, what happens is, because all these fractures, they are occurring at metaphysis. At metaphysis, what is the problem? That the bone density is very, very low. Now, जहां टूटे वहीं जुड़ गए. Wherever the bone breaks, in whatever the position it is, fusion will occur at that part only. So, at metaphysis, bone density is very, very low. Healing is very, very rapid. देखो जी, क्या explain करें? For example, let's say these are the two bone fragments, 1 and 2. And let's say they are displaced a little bit. Fine. The healing will occur in this position only. So, after healing, the bone would be like this. Right? This will be the bone after healing. This will be the bone. So, this is a type of malunion. Fracture गलत तरीके से जुड़ गया. Yes, of course, myth also. ये दोनों तो भाई है ना जी. ये दोनों तो भाई हैं. Colles fracture. Fine. Remember, Colles fracture is going to give you dinner fork deformity, and this is going to give you garden spade deformity. This is going to give you gun stock deformity. मैंने यहाँ पे इसलिए नहीं mention किया. I didn't mention it because all these things, even in today's class, we have to study them in detail. Now, periosteum. So, periosteum, it has got two layers, outer fibrous layer and inner cellular layer. Now, it has got stem cell. If need be, they can convert into osteoblast and they will form bone. If need be, they will convert to chondroblast and they will form cartilage. Fine. If need be, they will convert to fibroblast and they will form collagen. Now, these stem cells of the periosteum, they help in fracture healing. They help in infection control. They help in tumor management. They help in tumor management. Tumor management. Right? Okay. Now, let's see what is the importance of periosteum. Right? Now, see. So, periosteum, it is absent over intra-articular part of the bone. Periosteum, it is absent over two things. It is absent over intra-articular. That means part of the bone which is inside the joint. Part of the bone which is inside the joint. Right? Now, it is absent over sesamoid bones. For example, it is absent over patella. Right? Now, see. I told you that periosteum is super important in fracture healing, in infection control, in tumor control. Let's see. Now, so this is proximal femur and this is neck of the femur, right here. So this black line is periosteum. So neck of the femur has got no cellular periosteum. So that is why non-union is common in neck of the femur fracture. It is common in neck of the femur fracture. Neck of the femur has got no cellular periosteum. So if a fracture occurs here, let's say if a fracture occurs here at the neck of the femur, right? See here. If a fracture occurs here at the neck of femur, this fracture will heal very, very slowly, very, very slowly. In fact, in some patients, this fracture will not heal at all because there is no support of periosteum. इससे थोड़ा सा ही दूर, slightly far away here, like this. If the fracture occurs here, this is called as extracapsular fracture. Now, extracapsular fracture, it heals rapidly. Why? Because you see this fracture is at metaphysis. Bone density is very low. Fracture will heal very, very rapidly. इतनी कम है bone density, थोड़ा सा कैल्शियम आएगा, ये फ्रैक्चर भर जाएगा. फ्रैक्चर ने बॉडी को बोलना है कि मालिक थोड़ा सा कैल्शियम दे दो, हमारा काम हो जाएगा. Fine. A little calcium will help in healing of this fracture. But here, neck of the femur fracture, no help is coming from the periosteum because the periosteum is not there at all. Periosteum है ही नहीं, कहाँ से help करेगी? This is the importance of periosteum, right? Now, what exactly is non-union? Non-union is fracture which fails to unite in 9 months. 9 months. 9 महीने हो गए, फ्रैक्चर ही नहीं जुड़ा, 9 महीने में तो बेबी हो जाए पूरा पूरा, right? Now, what is delayed union? Fracture which heals to unite in 5 months. Right? They ask you what is the most common clinical feature of non-union. ये question आया हुआ है. This is the PYQ. What is the most common clinical feature of non-union? That is tenderness. Tenderness is the most common clinical feature of non-union. Is the most common clinical feature of non-union. Right? We'll move forward. Now, these are the common bones. These are the common bones where non-union of the fracture occurs. इन्हीं बोन पे अगर फ्रैक्चर हुआ तो नॉन यूनियन होकर रहेगा. निमोनिक इज फ्लट्स. फाइन. आप वर्ड्स को अल्फाबेट को थोड़ा इधर उधर कर लो, अच्छा निमोनिक बन के निकलेगा. ओके, सो सी फीमर नेक, पुअर वैस्कुलैरिटी. लेटरल कंडाइल ऑफ ह्यूमरस, देयर इज मसल पुल. लोअर थर्ड ऑफ अल्ना, पुअर vascularity. Fine. That is the same for talus. That is the same for tibia. And scaphoid also, poor vascularity. So these are the bones where you see the non-union of fracture is very, very common. Non-union of fracture is very, very common. Right? Okay. Now, what do you get to see over here? What is this X-ray showing you? What do you think this X-ray looks like? Now, this is a post, it's a complication, fracture complication. So here, this fracture is again showing you non-union. Fracture is showing you non-union. Most common cause is lack of immobilization. Most common cause is lack of immobilization. Lack of immobilization. Most common sign, as I told you, is tenderness. Tenderness. So here, what are the fracture of necessity? Fracture of necessity are those fracture where surgical treatment is absolutely necessary. Surgical treatment is absolutely necessary. For example, supracondylar fracture of humerus, if it is displaced. Galeazzi fracture, Monteggia fracture, Galeazzi fracture and Monteggia fracture. Lateral condyle of humerus fracture, lateral condyle of humerus fracture. Now these are some of the fractures of necessity, For those of you who want to go a little deep, fine, you see here, macro movement, it promotes non-union, right? Whereas micro movement, it promotes union. Micro movement. So you move a little bit. Let's say there is a fracture in the humerus. You move the humerus a little bit. Blood supply will increase. But if you move it like this, fracture will not unite. So macro movement will cause non-union. Micro movement will definitely cause union. Will definitely increase the speed of fracture union. Okay. Now, then the next complication of a fracture which we have to read is avascular necrosis. Bones where the avascular necrosis is common. So as you can see, what is this image showing you? This image is showing you scaphoid avascular necrosis, which is common in the proximal pole, avascular necrosis of the scaphoid. So these are the bones where avascular necrosis is common, right? Again, this is just a one-liner, right? We'll move to the next thing. Now, these are the causes. These are the causes of avascular necrosis. So there is a mnemonic which you can remember, STARS. So steroid overuse, trauma, fine. For example, neck of femur fracture, alcohol overuse, radiation and sickle cell disease. What is the problem with sickle cell disease? With sickle cell disease, there is poor blood flow. Okay. Now here, something called as pseudo-arthrosis. You have to answer two questions. Okay, first, just answer one. What is the most common cause? Pseudo-arthrosis is creation of false joint. After fracture. What is the most common cause? Answer please, anyone. What is the most common cause and what is the most common association? So, most common cause is idiopathic. जो चीज आपको नहीं पता, दुनिया भर के बड़े बड़े डॉक्टर्स को भी नहीं पता, right? So, pseudoarthrosis, most common cause is idiopathic. What is the most common association? Neurofibromatosis type 1 is the most common association, right? We'll go a little forward now. We will start with the metabolic disorder, and the first thing which we are going to study is rickets. Rickets. What is the most common cause of rickets in India? You see, India is a poor country, so most common cause is nutritional deficiency of calcium and vitamin D. What is the source of vitamin D? Sunlight. वो हमारे यहाँ खुले में मिलती है, right? And diet. Diet हमारे यहाँ पे poor है. Now, what we do is we make our own vitamin D. And what is that? 𝗘𝗱𝗶𝗁𝗋 by UVB rays. कैसे याद रखना है? UVA rays, they cause aging. UVB rays, they build bones. And if we get too much of UVB rays, we get sunburns. Okay. Now from diet, what we get is 𝗘𝗱𝗶𝗁𝗋. 𝗘𝗱𝗶𝗁𝗋. They both are practically useless because they are not metabolically active. ये दोनों metabolically active नहीं है. They are not useless. मान लीजिए आपने रोटी खानी है, बाजार से आटा ले आए, कोई फायदा तो है नहीं उस आटे का, आटे को फक्की मार के थोड़ी ना खाओगे. Then first आपको you'll have to knead the dough, then you'll have to roll the chapatis, and bake the chapatis. Same way, this 𝗘𝗱𝗶𝗁𝗋 is inactive, 𝗘𝗱𝗶𝗁𝗋 is inactive. It will go multiple level of processing, right? So liver processing. Liver will do the processing and liver will convert it into calcidiol. अगर बिना प्रोसेसिंग के सब कुछ चल जाता तो हमारे जैसे लोग तो अंगूर ही खाते रहते हैं हर समय कि अंगूर खा लो, अंदर जाके शायद कुछ और बन जाए अंगूरों से, right? Now kidney processing. Kidney will do the processing and it will convert into calcitriol. Now calcitriol is metabolically active. Fine. Now the clinical features are soft bones. Now comes the PYQs here. Now craniotabes. Why craniotabes is important? Because this is earliest clinical feature seen in rickets. Fine. Now this is also called as ping pong skull, also called as ping pong skull. So what exactly is craniotabe? Softening of the skull at the suture line. Softening of the skull at the suture line. Now what happens in rickets? That the brain is rapidly expanding in children. The problem is that the skull is soft. Now the soft skull is very easily deformed. Fine. So this deformed skull, what we call, that is called as frontal bossing. Yes, more like, a hydrocephalus like skull, right? G. Okay. Then what is this? Harrison sulcus. You call it Harrison sulcus. You can also call it Harrison groove. See. Now this develops due to pull of diaphragm. Right? So this is Harrison sulcus. Right? So this usually is asked as an image-based question. वो हमारे डॉक्टर साहब थे, उन्होंने कहा था कि निशान लगा दो उसके ऊपर. मैं याद रखूंगा डॉक्टर साहब आगे से. Now, you see this multiple bead-like appearance. वो साधु लोग देखते हैं मनकों की माला फेरते रहते हैं, right? That is a rosary. So this is rosary bead appearance. Now, in your practice, you will primarily see two kind of rosary. आपको दो तरह की rosary appearance दिखाई देगी. One is rachitic rosary. ये आपको दिखेगी rickets में. And second is scorboutic rosary. This you will get to see in scurvy. Now, rachitic rosary is painless. Scorboutic rosary is painful. Now, in one of the classes, student asked me, sir, why is corbotic rosary painful? मैंने जवाब दिया उनका, लेकिन उनसे पहले कुछ पूछ लिया. मैंने उनको पूछा, just tell me what is the common clinical feature of scurvy? जब भी हम स्कर्वी पढ़ते हैं, आपके दिमाग में सबसे पहले क्या आता है? फाइन. उनका आंसर था, सर स्कर्वी पढ़ते हैं तो कॉमन क्या है? गम ब्लीडिंग. फाइन. So that means bleeding is very, very common in scurvy. So here, why it is painful? It is painful due to subperiosteal bleeding. Subperiosteal bleeding. If you touch it, it will be rounded. It will be rounded. If you touch it, it will be angular. नुकीली सी होगी बिल्कुल. It will be angular, right? Then multiple deformities are there. I'll zoom it up. Fine. For example, you see here. Now this is genu valgum. Why it is genu valgum? Because you see that the feet, they are going outward. So anything wrong with the knees, name of the deformity automatically becomes genu. Right? So genu valgum. Now see, genu valgum is also called by some other name. Genu valgum is also called as bow leg. Like this. You see, this is a bow string, right? And then an arrow. So genu valgum is also called as bow leg, fine? And here. Now you see, again, the feet, they are going inward. The part of the body distal to the knees क्या है? पैर. और वो जा रहे अंदर की ओर. So now your patient is developing genu varum. And if you see correctly, there is an O forming. So it is said that genu varum is common in osteoarthritis, and genu valgum, it is common in rheumatoid arthritis. Now have a look at this unfortunate child. In the left leg, the child has got genu valgum. In the right leg, child has got genu varum. ऐसा लगता है जैसे इधर से हवा आई और बच्चे के पैर बहा के ले गई. As if the wind came from this direction and feet of the child moved in the opposite direction, right? So that is why this is called as wind sweep deformity. Wind sweep deformity. I'm really sorry. So I spoke the opposite things. Really sorry. So this is knock knee. I'm really sorry. And this one is bow leg. This is knock knee and this one is bow leg. Really sorry. Knock knee. Now I also have got knock knee. Fine. I'm really sorry. Really sorry. So this is bow leg. So genu varum is called as bow leg and genu valgum is called as knock knee. My terrible bad. Fine. So this is knock knee and genu varum is bow leg. Right? Now most common cause of wind sweep deformity overall is rickets. But most common cause of wind sweep deformity in adults is rheumatoid arthritis. In adult, it is rheumatoid arthritis. Right? Yes. Valgum. यहाँ पे gum लगा दी. Fine. So valgum. Now, about the test values in rickets. Now, serum calcium is either low or normal. Now, who does the normalization? Normalization is done by the parathyroid gland. Parathyroid hormone secreted by parathyroid gland. Fine. But there is no compensatory mechanism for phosphate and vitamin D. So phosphate and vitamin D levels, they remain low. Okay. Now, then alkaline phosphatase levels, they are high. Remember, our patient is a growing child and bones are being formed. So alkaline phosphatase is a marker of bone formation. Now, if alkaline phosphatase is a marker of bone formation, what is the marker of bone resorption? What is the marker of bone resorption? Hydroxyproline and deoxypyridinoline. Deoxypyridinoline. These are the markers of bone resorption. These are the marker of bone resorption. Okay, we'll move forward. That was about the rickets. Now here, what are the X-ray findings? What are the X-ray findings? See, the problem with the rickets is that there is lack of calcium. Everywhere the problem is that there is lack of calcium. Right? Now, you see, if there would have been enough calcium, अगर अच्छा खासा कैल्शियम बोन के पास होता, तो बोन इस एरिया को कभी भी खाली ना रखती, जिसको मैंने अभी शेड किया, बोन इस एरिया को कभी भी खाली ना रखती. But because bone does not have calcium, this area is devoid of calcium. Fine. So this particular finding on X-ray, this is called as cupping. This is called as cupping of metaphysis. Cupping of metaphysis. So basically, what is cupping? Deepening here. Let's see it on the X-ray. So this is cupping. Cupping of metaphysis. Fine. Then what is splaying? Do you see here? This is the normal width of metaphysis. But here, because the bone is weak, so splaying means widening of metaphysis. Widening of metaphysis. What is fraying? Fraying means rough edges of metaphysis. Rough edges of metaphysis. You see here. Rough edges of metaphysis. Right? Now see. So these rough edges, that is called as fraying. That is called as fraying. This deepening is called as cupping. And this widening is called as splaying. This widening is called as splaying. Now, when you start the treatment, phosphate levels, they begin rising within 96 hours. They begin rising within 96 hours. Radiological healing is visible as early as within 6 to 7 days at the earliest, and 6 to 7 weeks in 100% of the patient. 100% of the patient, it is visible within 6 to 7 weeks. Deformity correction. Now, this is a question which has been asked previously. When we do the deformity correction is done when alkaline phosphatase levels are normal. Now, this deformity correction is done with braces. But if we have to do surgery, so surgery will be done only when the skeletal maturity is reached. Skeletal maturity is reached. Only then we will do the surgery. Right? We'll move forward. Now, what are the other features? Pectus carinatum. Let's say if this is the normal chest, AP diameter, pectus carinatum would be like this. So increased AP diameter. If the normal malleoli is like this, double malleoli would be like this. double malleoli sign, delayed closure of fontanella and dental hypoplasia, right? Now, osteomalacia, it is also called as adult onset rickets. When do you see it? This is seen in women of developing countries, women of developing countries, right? Developing countries. Why? Because developing countries poor diet, and in developing countries the bodies of the women, they remain covered. They remain covered. अब देखो मेल लुंगी बनियान पहन के घूम रहे हैं, right? So their bodies get some sunshine. But females can't even wear skirts in our societies. So their bodies will not get sunshine. So they will have deficiency. They will have deficiency. Anterior. Basically, all the fontanella are delayed, but anterior most, right? So clinical feature are polyarthralgia and polymyalgia. Polyarthralgia means multiple joint pain. Polymyalgia means muscle pain. Now, X-ray will show milkman fracture. एक बार किसी क्लास में मुझे पूछा कि सर ये मिल्कमैन फ्रैक्चर क्यों है, क्यों नाम है इनका मिल्कमैन? तो जी मैंने बहुत ढूंढा, कुछ नहीं मिला। अल्टीमेटली क्या पता चला कि मिल्कमैन कोई डॉक्टर साहब थे, उनका फैमिली बिजनेस था, उनका फैमिली नाम था, पुराना सरनेम जो होता, दैट वाज मिल्कमैन। तो डॉक्टर मिल्कमैन साहब के नाम से इन फ्रैक्चर का नाम पड़ा मिल्कमैन फ्रैक्चर, मिल्कमैन फ्रैक्चर। इनका दूसरा नाम क्या है? सूडो फ्रैक्चर, right? Milkman fracture या pseudo fracture. Okay, right. Now they are insufficiency fracture. They are insufficiency fracture, and they are thought to be due to continuous pressure of pulsating arteries. बार बार पास पड़ी आर्टरी ढप ढप करके टकराएगी इससे, तो क्या डेवलप हो जाएगा? जोन्स ऑफ रेरिफेक्शन, जोन्स ऑफ रेरिफेक्शन। रेरिफेक्शन मींस कुछ जगह से बोन की डेंसिटी कम हो जाएगी और वो फ्रैक्चर की तरह दिखने लगेगा, राइट? लेट्स मूव फॉरवर्ड। द मोस्ट कॉमन साइट लोअर लिम्ब, और ये कहाँ नजर आते हैं? नेक ऑफ फीमर, नेक ऑफ फीमर, right? Yes, they are, I mean, they are not considered hallmark. They are seen in other diseases also. But what is the definitive diagnosis? Definitive diagnosis is trans-iliac bone biopsy. Trans-iliac bone biopsy. ये क्या दिखाएगी? Rarefaction. That means decreased bone density. Decreased bone density. Now I forgot what kind of pelvis we get to see. So the pelvis we get to see is triradiate pelvis. Tri ऐसे ट्रायंगल की तरह नजर आएगा, triradiate pelvis. अब इजी क्वेश्चन पूछना है एग्जामिनर तो triradiate pelvis. डिफिकल्ट क्वेश्चन पूछना तो rather than triradiate he will write as ortho pelvis. Triradiate pelvis, ortho pelvis. Pseudo fracture versus fracture. Cortex will be broken. Cortex will be broken in a complete fracture, in a real fracture. In pseudo fracture, the cortex is usually not broken, because you see on the second view, you will notice that the cortex is not broken, right? Now, scurvy. It is also known as Barlow disease. It occurs due to deficiency of vitamin C. Now, it is seen in young children and elderly. Why? Because of poor diet, because of canned food, right? Now, it doesn't develop during first 6 months because the mother's milk has vitamin C. So, mother is going to give sufficient vitamin C. Now, this is the typical X-ray, and this image has been asked several times. Now, you see here, in this image, this is the periosteum. This is the periosteum. Now, below the periosteum, you see some decreased density. What is that? Hemorrhage. Hemorrhage means bleeding, collection of blood, hematoma, right? And then you see here, this dark zone. This dark zone is called tumor-filled zone. Tumor-filled zone. And then this is zone of Frankel. This is zone of Frankel. Now this is epiphysis, this is metaphysis. Around the epiphysis, you see white colored zone of calcification. That is called as Wimberger ring sign. अगली पेज पे ये सारा कुछ लिखा हुआ. Wimberger ring sign. It is seen around epiphysis. Many of the students are confused, sir, how to differentiate between healing rickets and scurvy. Between healing rickets and scurvy. So healing rickets, you will get to see line of Frankel. Scurvy, you will get to see line of Frankel. But in scurvy, you will get to see white line around the epiphysis also. Wimberger ring sign. And then you will see sharp edges at metaphysis. What are they called? They are called as Falcon spur. They are called as Falcon spur. See, so what you get to see here? Pencil thin cortex. Then white line of Frankel, that is zone of calcification. Zone of calcification. Trummer-felt zone. Transverse lucent band in the metaphysis. So they appear dark black. They appear dark black. Wimberger ring sign. So Wimberger's ring sign is zone around epiphysis. Is zone around epiphysis. Fine. Now, this appears white. This appear white. Falcon spur is metaphyseal spur. Metaphyseal spur. Now this occurs due to micro fracture. This occurs due to micro fractures. Micro fractures. Right? Let's move forward. Fibrous dysplasia. Fibrous dysplasia. What happens in fibrous dysplasia? Failure of the bone to form mature lamellar bone. That means, technically speaking, bone is immature. Bone is immature. Fine. We say the bone is woven. Right? Now, sporadic, but it may be associated with McCune-Albright syndrome. McCune-Albright syndrome. Now, monoostic. Monoostic means single bone is involved. Now, in this, ribs are commonly involved. Whereas polyostic, what is the most common bone? Femur. And which region is commonly involved? Diaphysis and metaphysis. What do they ask here? They ask Shepherd crook deformity. तो ये रहे शेफर्ड, भेड़ बकरियां चराने वाले शेफर्ड, और ये हाथ में जो उनके डंडा है, that is called as crook. The stick in the hand of the shepherd is called as crook. Bone appears like this. Bone appears like crook of the shepherd. Yes. I mean, Those are the association of syndromes, but we are concerned with the bone feature. We are concerned with the bone features, right? Like this, orthopedics. About the details, but here we will just be focusing on the orthopedic features of fibrous dysplasia, right? Good, good, good. When you share this, this increases the knowledge of your teacher, and of course, increases the knowledge of your fellow friends also, right? Let's move forward. Osteoporosis, fine. Type 1 is post-menopausal. Type 1 is post-menopausal, right? We are talking about primary osteoporosis. Primary osteoporosis means your patient has no other disease. Only disease which your patient is suffering is osteoporosis, right? Now, secondary osteoporosis, most commonly it occurs with steroid use, right? Now, it also occurs with rheumatoid arthritis. With rheumatoid arthritis, it is periarticular. That means around the joints. Ankylosing spondylitis, hyperparathyroidism, and thyrotoxicosis. Now, what is the reason? What is the reason of senile osteoporosis? Peak bone mass is seen at 30 to 40 years of age, and after that it declines at the rate of 0.5% every year. 0.5% every year. So in osteoporosis, what is the most common clinical feature? Most common clinical feature is low backache. Low backache. Fine. Now here, what is this clinical feature? This clinical feature is called as 𝗘𝗱𝗶𝗁𝗱 hump. 𝗘𝗱𝗁𝗱 hump. Now, what is this? This is a typical X-ray finding. This is a typical X-ray finding. Typical X-ray finding. Right? Like this. Now, this is the mouth. This is called as fish mouth vertebra. Fine? Or codfish vertebra, whatever you want to call it. Right? So, this is fish mouth vertebra or codfish vertebra appearance. So this is seen when 30 to 40% of the bone mass is lost. So we need a better investigation. We need a better investigation. What is that? DEXA scan, dual energy X-ray absorptiometry, right? Now here, what do we measure? We measure bone mineral density at the pelvis and lumbosacral spine. Pelvis and the lumbosacral spine. Now, when bone mineral density of your patient is compared with race and gender matched younger individual, what do we get? We get something called as T-score. When bone mineral density is compared with race, age, and gender matched individual, what do we get? Z-score or Z-score. See, dear doctors, T stands for teacher. When you compare the bone mineral density of an old teacher with a young student, you get T-score. Z-score. A, B, C, D, E, F. When you read ABC, Z comes at the end. In the end, everyone is equal. You are playing chess. रानी बहुत powerful, राजा बहुत powerful. जब खत्म हुई chess, सारे एक डब्बे में बंद. So in the end, everything is equal. So in the Z score, race, age, and gender, everything is equal. So when you compare the bone mineral density of your patient with someone of the same age, race, and gender, what will you get? You will get the Z score. What is more important? T score. Now, if the T score is between -1 to 1, +1, that means everything is normal. The T score is between -1 to -2.5, we say that your patient has osteopenia. Now, if it is between -2.5 to -4, we say that our patient has osteoporosis. Our patient has osteoporosis. Yes, yes, yes. So, fracture in osteoporosis, they are called as fragility fracture. Now, where are they common? They are common in the dorsolumbar spine, fine. Then they are common at neck of femur, and then they are common at the wrist joint. Then they are common at the wrist joint. They are called as fragility fracture. Fragile matlab easily breakable, the one which can break easily, right? Okay, what is the treatment? So you see here, up to this, these are the drugs which inhibit osteoclast. And this is the drug which increases the activity of osteoblast. And this one is a dual action drug. Now, what are the drugs which decrease the density of osteoclast? Osteoclast are those cells which resorb the bone, which destroy the bone. Bisphosphonate, alendronate, risperidone. Fine. Now, they are to be had once a week. Ibandronate, once a month. Zoledronic acid, once a year. Estrogen given as a part of hormone replacement therapy. Selective estrogen receptor modulator like tamoxifen. Calcitonin. So calcitonin is considered anti-hormone to parathyroid hormone. What does it do? It shifts calcium from blood to the bones. Denosumab, it is a monoclonal antibody against osteoclast. Teriparatide. Now, what is teriparatide? Teriparatide is synthetic parathyroid hormone. Now, at low doses, it stimulates bone formation. At high doses, it does the opposite. It stimulates bone resorption. Strontium ranulate, it's a dual action, but still not used because this is nephrotoxic. Bisphosphonates are used, let's say, if there is like severe osteoporosis. Yes. Now, fractures are common at dorsolumbar spine. They are common at neck of femur, fine, and common at wrist joint. Colles fracture, right? Now, surgical treatment is vertebroplasty, fine. So, PMMA, bone cement, polymethyl methacrylate acetate, right? Now, please answer this question. See, because I wanted to save some time, so the important thing I have written in the red line, one thing: never trust the examiner. Never trust the examiner. Now the answer is medicine-related acute osteonecrosis of the jaw. So this is a complication. Osteoradionecrosis. It is the complication of long-term bisphosphonate therapy. Long-term bisphosphonate therapy. Then, what is other complication of bisphosphonate therapy? Atypical fractures. Atypical fractures. So, atypical fractures, they are the complication of bisphosphonate therapy. Complications of bisphosphonate therapy. Complication of bisphosphonate therapy, right? Okay, let's move forward. Osteogenesis imperfecta. This is also known as brittle bone disease. Brittle bone disease. Now, there is defect in the collagen type 1. Collagen type 1. Fine. So, any structure having collagen type 1 is defective. Any structure having collagen type 1 is defective. What is the defect? Col1A1, Col1A2. And how is this transmitted? Autosomal dominant. Autosomal dominant. Right? Defective gene. Okay, there was space. I'm sorry. Col1A1, Col1A2. Now, what are the clinical features? Hyperlaxity. That means loose ligaments. Loose ligament. Fine. Blue or gray sclera. Blue sclera or gray sclera. Multiple fractures, but healing at normal rate. Multiple fracture, but healing at normal rate. In one of the classes, a student asked me that, sir, why the fractures heal at normal rate? I said, what is the problem in osteogenesis imperfecta? Bones formed are defective. Okay. Now, when the fracture occurs, healing occurs, the bone which is formed is still defective. Read my statement again. Fractures heal at normal rate. So the prominent word is rate. उनको नहीं समझ में आया. मैंने उनको बोला देखो जी खाना बनाते हैं घर पे मैं और मेरी वाइफ. तो मेरी वाइफ ने खाना बनाया, मान लो मैंने खाना बनाया, राइट? वो अच्छा खाना बनाती है, मैं खराब खाना बनाता हूँ, राइट? तो किसी दिन अगर खाना बनाना है, मैं भी खाना बनाऊंगा, वो भी खाना बनाएंगे, सेम स्पीड से खाना बनेगा. उनका अच्छा बनेगा, मेरा खराब बनेगा. स्पीड में कोई अंतर नहीं, क्वालिटी में अंतर हो सकता है. So here the bone formed is bad, but it will form at the same speed. So fracture they will heal at the same rate, right? Normal rate. Treatment is bisphosphonate and the surgical treatment is Schofield Miller osteotomy. Now this is called as 𝗘𝗱𝗶𝗁𝗱 osteotomy. 𝗘𝗱𝗶𝗁𝗱 osteotomy. 𝗘𝗱𝗶𝗁𝗱 osteotomy. Right? Now, osteoporosis, also called as marble bone disease. So here there is no bone resorption. No bone resorption. Old bone keeps on accumulating. Old bone keeps on accumulating. पुरानी bone destroy नहीं होगी, इकट्ठी होती रहेगी. Right? Now, what do we get to see? This is the finding which we get to see on X-ray. Endobone appearance. Endobone appearance. Endobone को हम लोग क्या बुलाते हैं? Endobone is also called as bone within bone. Bone within bone. It is also called as sandwich vertebra. Sandwich vertebra. Right? Now this Erlen-Meyer-Flask deformity. Erlen-Meyer-Flask deformity. So see here, the lower end of the bone, it appears like a flask. Which flask? Erlen-Meyer-Flask. Erlen-Meyer-Flask. Like this. See, Erlen-Meyer-Flask. the lower end of the bone, it appears like Erlenmeyer flask deformity, right? Now, treatment here is stem cell transplantation, right? Let's move forward. Paget disease, also called as osteitis deformans, right? Now, Paget disease, what kind of mutation is there? SQSTM1. And what kind of virus? Epstein-Barr virus, right? So, broad term will be Coxsackie virus, right? The common bones affected are femur, pelvis, and tibia. Now, the disease passes through three phases: lytic, blastic, and sclerotic. So, in lytic phase, osteoclasts are hyperactive. In blastic phase, osteoblasts are hyperactive, and sclerotic phase is late inactive phase. Male-female ratio is equal. Most common age, it is seen at more than 50 years of age. Clinical feature. Most common clinical feature is bone pain, right? Headache also occurs. Hearing loss. Now, this is a mnemonic pain, right? We'll see each one of this. So, cranial nerve palsy commonly occurs and it affects these nerves: 2nd, 5th, 7th, and 8th cranial nerve. Vascular steel syndrome. So, thick skull bones, they demand more blood. Thick skull bones, they demand more blood. यहाँ से blood गया, skull में जाना था, brain को जाना था. Less blood goes to the brain and more blood goes to the bones, right? Now, what kind of fractures are there? Banana fractures, like this. You see, banana fracture. Let's say this is the long axis and this is the type of fracture. You see here, there is a fracture, banana fracture. So, you see here, banana fractures. So, what kind of fracture are they? They are transverse fractures, right? Banana fractures. Okay, now here, these are the clinical features seen during lytic phase. So, you see here, this area, there is deficiency of bone. Bone is destroyed. This sign, it is called as blade of grass sign. Let me erase it and let me zoom it up so that you can see it. Blade of grass sign. Now, this is also called as candle flame sign. Let me zoom it up for you. See here. So, in this area, which I am going to shade, what you notice is that the bone density is low, whereas everywhere else, the bone density is normal. So, this is called as candle flame sign or blade of grass sign. ये रहा घास का पत्ता. Blade of grass sign, right? Now, then in the next phase, what do we get to see? We get to see cotton wool skull, that is thickened skull table, cotton wool skull, thickened skull table, cotton wool skull. Okay. Now, again, Next thing what we get to see, it is called as picture frame vertebra. Picture frame vertebra. Like this, picture frame vertebra. So you see here, picture frame vertebra. Here the bone density is high, whereas here the bone density is normal. Now there, in the next stage, you will get to see this. Now this is called as ivory vertebra. Ivory vertebra. If you do the bone density, you will get to see this picture. This is called as mosaic bone. Jaldi ka kaam shaitan ka, right? So mosaic bone, haphazard, disorganized bone. Disorganized bone. Now, in the late stages, your patient will wear this kind of hat. That is called as Tam-O-Shanter sign. Tam-O-Shanter sign. Tam-O-Shanter sign. What is the treatment? Bisphosphonate, calcitonin, and in the later stages, the only treatment is osteotomy. So Tam-O-Shanter sign. What is that? Increasing skull size. Right? Let's go forward. Achondroplasia. Now, achondroplasia is said to be most common cause of genetic dwarfism. Most common cause of genetic dwarfism. What are the clinical features? Short height. Fine. Decreased arm span. But the important clinical feature which is often asked in the questions is that the IQ is normal. What is the inheritance pattern? Autosomal dominant. 80% of the patients are still fresh mutation. There is no family history. Right? What is the gene responsible? FGFR3, fibroblast growth factor 3 gene mutation. अब इसका एक गंदा वाला वेरिएंट आता है, thanatotropic dwarfism. Thanatotropic means death loving. Now here the chest is so small that your patient is not able to breathe. Okay. Now see. So this is a family living somewhere in Kerala. They got married और इनके बच्चे भी जो हुए unfortunately उनको भी निकल आया achondroplasia. Now here, what is the characteristic clinical feature? Rhizomelic micromelia. Melia or milia, whatever you want to write. Micro means small, milia pertains to the limbs. And rhizomelic means shortening of the bones. Shortening of the bones is prominent in proximal limbs. Is prominent in proximal bones or prominent bones. Proximal bones. Right? Here. So proximal bones, for example, humerus. Proximal bone, for example, femur. They will be very, 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 very small. Okay? Rhizomelic micromelia. Now then, your patient will have starfish hands. Fine? You see, like starfish, simian crease, single prominent line. And you notice that there will be wide gap between middle finger and ring finger. Wide gap between middle finger and ring finger. Okay, simian crease, single prominent line. Okay, now here, so you see here for champagne, they have got a glass which is very, very wide, but not very tall. Not very tall. Honestly, before I read achondroplasia, मुझे नहीं मालूम था कि शैंपेन का ग्लास ऐसे चौड़ा होता है. हमें तो लगा था शैंपेन का ग्लास वही लंबा सा होता है. Right? Now here, what kind of pelvis is this? So this is called champagne glass pelvis, champagne glass pelvis. Now this pelvis is very wide and not very tall, fine. And when you get to see the X-ray, you will get to see bullet shaped vertebrae. You'll get to see bullet shaped vertebrae. Nevertheless, they are living a happy life. They seem quite happy. अच्छी बात है, right? लंबे होके भी किसी ने कोई क्या ही कमा लेना है, right? Now here, what I've done is I've compared all of them, all these things which we read. I've compared all of them in just 2 pages. I've compared all of them in just 2 pages, right? One is this and second is this. Now they are also a part of the PDF. They are also a part of the PDF. So this is for super rapid revision, last minute revision, that in 20-30 seconds you want to revise all of them. Okay. Now we will see some of the important fractures. Make my day and tell me what is the name of this fracture. What is the name of this fracture? So if you get to see tibia plateau fracture, tibia plateau fracture, fine, and it is a big fracture. This is just as a mnemonic. So B for big, B for bumper fracture, bumper fracture. So what happens is bumper fracture. Some car hits your patient's knee from behind and tibia goes outward. So this is caused by valgus force, right? So see B, big, B, bumper. Now, if you see a small fracture, on tibia, so small fracture is C-gond fracture, C-gond fracture. So C-gond fracture is associated with lateral collateral ligament injury. It is associated with anterior cruciate ligament injury, right? So S for small, S for C-gond, B for big, B for bumper, right? Now see here. Okay, so where do you get to see fracture in the first image? You see here, right? So if you get to see fracture at C6, C7, and your patient happens to be alive, that is 𝗘𝗱𝗏𝗯𝗓 fracture caused by abrupt flexion. And if unfortunately your patient is dead, that is called as undertaker fracture, Dead body is treated with respect, should be treated with respect. Now let's say who are undertakers, who take the body inside the grave. Undertaker कौन लोग हैं जी? जो dead body को कब्र के अंदर लेके जाते हैं. They handle it very, very gently. But if they don't handle it gently, body will fall and posterior part of the spine will suffer a fracture, C6, C7 fracture. That is called as undertaker fracture. It is a post-mortem finding, right? Now, here, what you see that there is a fracture. So, C2 vertebra, it slips over C3, fine. तो ये फ्रैक्चर कौन सा हुआ जी? दिस इज hangman fracture. Hangman fracture. Very good. Now tell me, what is this fracture? Do you get to see any fracture here? This what you get to see. This is C2 vertebra and C1 vertebra के ये टुकड़े हैं. C1. They both have moved. Both have moved. So this is Jefferson fracture. Jefferson fracture. What it is? It is burst fracture. Burst fracture of atlas. Burst fracture of atlas. कैसे नजर आता है? It is seen in open mouth odontoid. Open mouth odontoid view. Now see here. So if medial and lateral malleolus both are fractured, what is the name? Pott fracture. So Pott fracture is bimalleolar fracture. And if posterior is also fractured, now the name changes. So now the name is trimalleolar fracture and it is called as cotton fracture. It is called as cotton fracture. Cotton fracture. So mnemonic PBCT, CT scan, cotton trimalleolar. Okay, PB, Pott, bimalleolar. Yes. Anyone, what is the name of this fracture? Two different fractures, 1 and 2. What is the name of this fracture? This, though is not very important, this is important probably only for NEET PG, only for NEET PG, but yes, you know, they can ask you anywhere. These are tarsal bones, right? These are metatarsal bones. So this is your typical Lisfranc dislocation, Lisfranc fracture dislocation, right? Now see, metatarsals. Now here, tarsals. And you see, tarsal bones के आपस के बीच में ही fracture हो गया. So what is this fracture? Transtarsal. Now this kind of fracture is called 𝗘𝗱𝗶𝗁 fracture. 𝗘𝗱𝗁 fracture dislocation. 𝗘𝗱𝗁, right? So this, what you get to see over here, 𝗘𝗱𝗁 fracture dislocation. And this one is Lisfranc fracture dislocation. Okay, let's move forward. Aviator fracture. Aviator fracture is fracture of talus. Fracture of talus. Now this fracture, very, very important. This is a PYQ, came this year, NEET PG. Fine. Now what is this fracture? This fracture is called as jackknife fracture. Jackknife fracture. This is also called as chance fracture. Now, what is the mechanism? Mechanism is flexion due to seat belt. Flexion due to seat belt. Anterior part of the spine fractured. Middle part fractured. Posterior part fractured. Every part of the spine is fractured. This is an extremely unstable injury, right? Now, how do you see that there is a fracture? Dekho, normal, 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 normal. Here, you notice So whenever you are looking at any fracture and you are not able to find, always look for the cortex of the bone. Bone का बाहरली हिस्सा पकड़ लो और उसको ट्रेस करते जाओ, फ्रैक्चर मिल जाएगा, गारंटी 100% मिल जाएगा, right? So look at the cortex of the bone. Jackknife fracture. Now see here. Jones fracture at the metatarsal. Now, when you look at the metatarsals here, right? So metatarsal, they are divided into three zones. Divided into three zones. So zone 1, it will have pseudo Jones fracture. Question क्या आता है? Jones fracture कहाँ होगा? It will occur in the zone 2. Zone 2 will have Jones fracture. See here. Now, so if you can see these images, so this is zone 1, right? This is zone 2 and this one is zone 3. Now here, this fracture is considered in zone 2. So this is a Jones fracture. Jones fracture. Now here, this fracture is occurring in zone 1. So this we will call it as pseudo Jones fracture. Pseudo Jones fracture. So this image is important. This image is important, right? So zone 1, pseudo Jones fracture, right? Zone 2 is the zone fracture and zone 3 is a stress fracture. It occurs in dancers, cheerleaders, right? Move forward. Now, skyline view is also known as sunset view, is also known as sunrise view. What is the use? Patellofemoral dislocation. जब मैं ये वाला व्यू निकाल रहा था तो ये फोटो एकदम से सामने आ गई. सब कुछ सेम है. फाइन. द नेम इज सेम. स्काई राइज, राइट? सनसेट व्यू. ओके, everything is same. Sunset view, sunrise view. Okay, so this is for patellofemoral dislocation. That means knee joint dislocation. Knee joint dislocation. Right? Now, let's move a little forward. Now, let's talk about the upper limb. Let's talk about the upper limb. After around half an hour, we will take a short break. Right? Now, upper limb. Here, what do you get to see? कई बार fracture नहीं भी नजर आता. Gartland classification. When I appear for the NEET PG examination in the year 2024, they ask question about Gartland classification. Gartland classification, right? Now see, Gartland classification here. You see undisplaced, incomplete fracture, type 1. Type 2, here you see like this. And here the cortex is broken. Cortex is broken. So this is green stick fracture. You see here the fracture is totally undisplaced. Fracture line will not be visible properly on the X-ray. And third type is completely displaced. So how do you get to see for the fracture? So how will we get to see for the fracture? So this bone is humerus, this is ulna, this is radius. In front and behind, you see. So if you notice here, now you see fat pad sign. You see slightly dark area. You see slightly dark area posteriorly. Now this is called as fat pad sign. You see slightly dark area anteriorly. This is called as sail sign. So this is seen in the lower end, supracondylar fracture of humerus, incomplete fracture. So in the front you will see sail sign and behind you will see fat pad sign. What is sail? This is the SAIL. SAIL sign and fat pad sign. जिक्र आया SAIL का. So SAIL sign is seen in another fracture, another fracture here. Salter-Harris type 2. Salter-Harris type 2. It will show SAIL sign. Salter-Harris type 2. It will show the SAIL sign. Salter-Harris type 2. It will show SAIL sign. SAIL sign. Okay. Salter-Harris type 2. So Salter-Harris classification is for physeal injuries. Now, Salter-Harris type 4, it is similar to lateral condyle of humerus fracture. It is similar to lateral condyle of humerus fracture. So there is fracture above, there is fracture below, fracture above and below. What? The physis. So this is similar to lateral condyle of humerus, similar to lateral condyle of humerus, right? आगे चलते हैं. Now clavicle. About the clavicle. Clavicle is the most common bone to get fractured overall. Fine. In children, as I told you, in children, most common bone to get fractured are the forearm bones. It is the only long bone which is horizontal. Tibia, femur, vertical. Humerus, vertical. Right? It has got no bone marrow cavity. Now, it forms by membranous ossification. Remember, long bones, they form by enchondral ossification. They form by enchondral ossification. It is the only, it is the most commonly fractured bone during delivery. But during difficult delivery, humerus is the most commonly fractured bone, right? Now, malunion is the common complication. Why? Because you see, outer fragment is pulled down by the gravity, inner fragment is pulled up by the muscles. So bone is entirely cancellous. Bone is entirely cancellous. So what do we expect? Because the bone is entirely cancellous, rapid healing would occur. Now most common site is outer 1/3 and inner 2/3 junction. Right? Treatment. If the fracture is undisplaced, we will use triangular arm sling or 𝗘𝗱𝗶𝗁 bandage. If the fracture is bilateral or displaced, we will use figure of 8 brace. We will use figure of 8 brace. Right? Okay. Now, surgery is done if the overlap is more than 2 centimeters, like this. Right? So you see, if this overlap is more than 2 centimeters, we will do the surgery. Fine. If the fracture is at ends of the clavicle, both end, whether it is at lateral end, whether it is at medial end, right? If the fracture is associated with neurovascular injury, for example, brachial plexus is injured. For example, subclavian vessels are injured. Now, surgery is done if the fracture of the clavicle is associated with floating shoulder, Now, as a part of PYQ, This is the only thing which I found important. Proximal humerus fracture. What is the most common site? Surgical neck of humerus. What is the classification system used? Neer classification. Neer classification. Nothing else is important, believe me. Right? Let's move forward. Elbow fracture in children compared. Most common fracture is supracondylar fracture of humerus. Second most common is lateral condyle fracture of humerus. 3 bony point relation is maintained. What are the 3 bony point? Lateral condyle, olecranon, and medial condyle. Medial condyle. What is the most common nerve injury? Anterior interosseous nerve. Fine. And then median nerve. And after that, radial nerve. Nerve injury common here is ulnar nerve. And that too is a late complication. That too is a late complication. Late complication. What is the complication here? Gun stock deformity. Gun stock deformity. And what type of deformity is this? Cubitus deformity. Here, what is the complication? Cubitus valgus. Cubitus valgus deformity. Nubulus. Cubitus varus. Treatment in both is surgical. Treatment of complication. Modified French osteotomy. Modified French osteotomy. Volkmann ischemic contracture. Now this occurs in supracondylar fracture. Supracondylar fracture due to brachial artery injury. Due to brachial artery injury. What is the blood vessel affected? Anterior interosseous artery. First muscle to be affected, flexor digitorum profundus. Flexor digitorum profundus. Now, what is important here? The image. What is the treatment? Turnbuckle splint. Turnbuckle splint. What is the surgical treatment? Max Page operation. Max Page operation or osteotomy. Okay. Gun stock deformity. First of all, it is just a cosmetic deformity. Second, it is a cubitus varus deformity. And what is the treatment? Modified French osteotomy. Modified French osteotomy. Pulled elbow, also known as nursemaid elbow. They ask you what is the most common age. 2 to 5 years. 2 to 5 years. What is it? Subluxation of the head of radius. Subluxation of the head of radius. The child will keep the elbow in prone position. ट्रीटमेंट इज क्लोज रिडक्शन. बच्चा ऐसे बाजू लेके आएगा, आपने पकड़ के ऐसे कर देनी है. फ्रॉम प्रोन यू विल ट्विस्ट टू स्पाइन एंड पुट सम प्रेशर ऑन द रेडियल हेड. पुल्ड एल्बो. This is already written. Hotchkiss, terrible triad, encephaloplasty. Now here, this what you get to see is Dunlop fraction. Dunlop fraction. This what you get to see is Smith fraction. Now both of them are for temporary stabilization. Temporary stabilization of supracondylar fracture humerus. Supracondylar fracture humerus. So they will just temporarily stabilize the fracture. Now, Holston-Lewis fracture. Holston-Lewis fracture is the fracture of humerus shaft. Humerus shaft plus radial nerve injury. Radial nerve injury. Okay. Now, if the humerus fracture, is not associated with radial nerve injury, what is the treatment? Treatment is U-slab, preferred over hanging cast. Okay. If nerve injury is present since the time of accident, this is going to heal automatically. So your patient will present to you like this. Your patient will present to you with wrist drop. Wrist drop. Fine. So wrist drop means inability to extend. Inability to extend the wrist. Right? Inability to extend the wrist. Now, nerve injury since the time of accident, injury will be neuropyrexia. Now the treatment is U-slab plus cock-up splint, right? Now, if nerve injury is not present since time of accident but develops after manipulation, now the nerve injury is neurotemesis. Now the surgery is open reduction internal fixation plus repair of the nerve. So you have to remember the important images. This is U-slab. This is hanging cast. And this is cock-up splint. No. The clavicle fracture surgery is very rarely indicated. Even in the elderly people, clavicle fracture will automatically heal. So in the first image, what do you get to see? You get to see nightstick fracture. So nightstick fracture is isolated fracture of ulna. Right? Now here, about the Monteggia and Galeazzi fracture. You have so many mnemonics. You have got so many mnemonics. Jo mnemonic pasand aaye rakh lo. Murg is the first mnemonic. So Monteggia will affect the ulna. Galeazzi will affect the radius. Then the other mnemonic is GFR. Galeazzi fractures the radius. First mnemonic, second mnemonic, and the third mnemonic, Grimus. So Galeazzi will fracture radius at inferior position. Monteggia will fracture ulna at superior position. Right? Now, you see, so this bone is radius, this bone is ulna. You see, What fracture is this? If you notice correctly, radius is perfectly fine and it is the ulna which is broken. It is the ulna which is broken. And then you see there is a dislocation also. There is a dislocation also. So what you get to see on your screen, it is a Monteggia fracture. It is a Monteggia fracture. Dr. Sinister ji, what is important in nightstick fracture is that there will be no other fracture. There will be no other dislocation, no other fracture, no other dislocation, right? So it is an isolated fracture. Now see this. So radius is injured, ulna is okay, and then there is dislocation. See here. Now radius is fractured, ulna is okay, and between the two of them there is dislocation. There is dislocation, right? Now this, what you see on your screen, is a Galeazzi fracture, right? Now Colles fracture, see, you need to remember this thing, that bone is broken into distal and proximal parts, and distal fragment, it goes posteriorly. Distal fragment, it goes posteriorly. Now clinical feature, your patient will present to you in supination and lateral angulation. Lateral angulation of the fingers. I for impacted fracture. And P, posterior displacement. Posterior displacement of distal fragment. Okay, that's a mnemonic for clinical feature. Slip. And what is the treatment? Treatment mnemonic is propaganda. Propaganda. So from supination we will convert to pronation. Fine. From supination we will convert to pronation. From dorsal angulation we will convert to palmar angulation. From lateral deviation we will convert to ulnar deviation. Ulnar deviation. And all this we will do in the handshake cast. We'll do this in the handshake cast. Handshake cast. Right? Some important things over here. I want to show you some important things over here. Some important concepts over here. Right? Okay. So whatever you see over here, that is anterior aspect of my body. Anterior aspect of my body. Now this is called anterior aspect. Anterior. If this is anterior, this is posterior. Anterior, posterior. Anterior, also called as ventral, also called as volar, also called as flexor. This is flexion. So anterior, ventral, volar, flexor surface. If this is anterior, this is posterior. If this is ventral, if this is volar, this is dorsal. If this is flexor, this is extensor. Now, so the first finger is the thumb, and that is my lateral most finger. Then the index finger, middle finger, then ring finger and little finger. So when I stand here in this normal neutral position, let's say if I twist my fingers like this, what is this? Lateral angulation. Neutral position, lateral angulation. Now if I shift to the inner side, this is called as medial angulation. Neutral position, lateral angulation. Neutral position, medial angulation. Neutral position, lateral. Neutral, medial. Neutral, lateral. Right? Now, when I do lateral angulation, my fingers are close to which bone? Radius. So, lateral angulation is also called radial angulation. Medial angulation is also called as ulnar angulation or ulnar deviation. So, very quickly, quick repetition. Medial angulation, medial deviation, also called as ulnar deviation. Neutral. Lateral deviation, also called as radial deviation. Neutral. Medial, also called as ulnar. Neutral. Lateral, also called as radial. Now see, my hands. Neutral position at the wrist. If I do like this, this is flexion. If I do like this, neutral. If I do like this, this is extension. So very quickly, neutral, flexion, also called as palmar flexion. Neutral, extension, also called as dorsiflexion, also called as dorsiflexion. Neutral, flexion, also called as palmar flexion. Neutral, extension, also called as dorsiflexion. 10-second quick recap, promise it won't take longer. Neutral position. If I do like this, medial deviation, also called as ulnar deviation. Neutral position. Lateral deviation, also called as radial deviation. Right? First finger thumb, middlemost finger, little finger. Right? Okay, so you see here. Now, if you notice, this is the distal fragment, and where does this go? This goes posteriorly. And what is the problem? Fracture is at metaphysis. Fracture is at metaphysis here, like this. Rapid early healing. So, your patient will develop a deformity which is called as dinner fork deformity. Dinner fork deformity, very, very bad kind of deformity. Dinner fork deformity is disabling deformity, What is the treatment? Treatment is DRACH operation, right? Now, Smith fracture is totally opposite. Smith fracture fall on inward turned hands. Clinical feature, the mnemonic will be propaganda. Treatment will be slip. Deformity will be garden spade deformity. Colles fracture and Smith fracture. Right? Okay. Now, very quickly, let us compare Colles fracture and Smith fracture. Right? So, Colles fracture, you notice that the angulation is dorsal. Right? Now, see, this is the joint. This is the fracture line. So, what kind of fracture is this? Extra-articular fracture away from the joint. Smith fracture What kind of angulation? Volar angulation. Volar angulation. Plus, you see, this is the joint and this is the fracture line. So what kind of fracture is this? Extra-articular fracture. Now let's see some other. See, here again, this is dorsal angulation. And you see, this is close to the joint. So what kind of fracture is this? Intra-articular. So this kind of fracture is called as dorsal Barton fracture. Look at the fourth one. What kind of angulation? Volar angulation. This is the joint and you see it is close to the fracture line. So what kind of fracture is this? Intra-articular fracture. Intra-articular fracture. So this kind of fracture is called as volar Barton fracture. So Smith-Colley extra-articular, Barton intra-articular fracture, right? Okay, this. So if let's say radius styloid process is fractured, that means intra-articular fracture, but there is no angulation. Hand of your patient is straight, neither volar, neither dorsal. Okay, so what is this? This kind of fracture is called Schaffer fracture, also called as Hutchison fracture, also called as backfire fracture. Now, can anyone tell me the name of this fracture? Now, you see, this is the lateral side, this is the medial side. So, if you get to see a fracture on the medial side, this is 𝗘𝗱𝗶𝗁 fracture. This is 𝗘𝗱𝗁 fracture. Schaffer is on the lateral side. Schaffer fracture is on the lateral side. Schaffer fracture, also known as Hutchison fracture, also known as backfire fracture. Fine. So this is the way we used to start the cars, and this handle will hit the radius. Now, scaphoid fracture. Scaphoid fracture, what is the mechanism? Fall on the outstretched hands in the young. Now, scaphoid, most common site is the waist. Fine. And distal fracture is common in children. Distal fracture is common in children, whereas proximal fracture is known for avascular necrosis. It is known for avascular necrosis. So, three kind of fractures. Distal fracture, it is the most common site in children. Waist is the most common site in adults, and proximal site is known for developing avascular necrosis. Avascular necrosis, right? So, what are the clinical features? Pain in the anatomical snuff box. Anatomical snuff box. What is the treatment? Treatment is glass holding cast. How will you identify this cast? Thumb will be covered. Thumb will be covered, right? What is the treatment for displaced fracture. So Herbert screw is the treatment for displaced fracture. Now this image will explain you why the avascular necrosis is common in the proximal pole. Blood supply to the scaphoid, it enters like this. It enters like this. Now, if the blood supply is interrupted like this, so naturally it is the proximal pole which will develop avascular necrosis, right? Avascular necrosis. Okay. Now here, the first image, it shows two fragments. So B for Bennett, B for bi, and bi means 2. B for Bennett, B for bi means 2. That is a way to remember. Next is Rolando. So there was a movie RRR. So Rolando fracture, minimum 3 fragments, right? So this is a way to remember. Bennett fracture is displaced fracture of base of thumb, and Rolando fracture is comminuted fracture of base of the thumb, comminuted fracture. So Bennett displaced, Rolando comminuted. Now here, so if the extensor tendon rupture, your patient will develop mallet finger. So mallet finger is extensor tendon rupture, right? Now, what is the treatment? Treatment is surgical repair. And what is the name of this splint? Stacks splint, right? Now, if the finger is in flexion here, right? If the finger is in flexion, so this is mallet finger, right? But see here. Now, if you see this image, what you notice that these fingers are normal, but this finger is abnormal. Why? Because you see there is no flexion. So this is called as jersey finger. What are the clinical features of jersey finger? There is no flexion. Why no flexion? Because there is injury to the flexor tendon. Now, what is the treatment? What is the treatment of jersey finger? Treatment of jersey finger is frog splint after surgical repair. Then skier thumb. Skier thumb is acute injury to ulnar collateral ligament. Fine. Whereas this is gamekeeper thumb. Gamekeeper, wild animal, they are called game. This is chronic injury to ulnar collateral ligament, chronic injury to ulnar collateral ligament. So syndactyly is fusion of fingers, and most commonly it is seen between middle and ring finger. Most commonly it is seen between middle and ring finger. So middle finger and ring finger, right? Polydactyly, more than 5 fingers, and most common is 2 or more than 2 thumbs, right? 2 or more than 2 thumbs. Now what is this? Spranger deformity. Spranger deformity. So what is the problem here? That there is a band between scapula and the cervical spine. Band between scapula and cervical spine. Now this is seen in 𝗘𝗱𝗶𝗁 syndrome. 𝗘𝗱𝗶𝗁 syndrome. Treatment is to cut the band excision between 3 to 8 years of life. 3 to 8 years of life. You know, Pushpa, like this. So there is a band between scapula and the neck. Patient has no choice but to keep it like this. So between 3 to 8 years of age, we will cut this band. We will cut this band between 3 to 8 years of age, right? Okay. So after we come back, we will start with the rest of the topics. Just tell me, what are the causative factors of rheumatoid arthritis? So it is associated with human simplex virus, Epstein-Barr virus, and smoking. Smoking is strongly associated with rheumatoid arthritis. Of course, it is autoimmune, but it is commonly associated with smoking. What is the first autoimmune disease to be discovered? Hashimoto thyroiditis, right? Now we'll start with the rheumatoid arthritis. Yes, it is an autoimmune disease. It is associated with HLA, DR1 and DRW4, right? Okay. Now, the cytokine involved: TNF alpha, interleukin 1 and 6. Most common joint, metacarpophalangeal joint. Metacarpophalangeal joint, right? That's the most common joint involved. Okay. Now, clinical feature: symmetrical polyarthritis, early morning pain, and it slightly improves with activity. Slightly it improves with activity. Now the deformities. So your patient can develop mallet finger. Mallet finger, see here. Mallet finger is just flexion at DIP joint, right? And then your patient can develop other deformity which is called as swan neck deformity. So there will be flexion at the DIP, and there will be hyperextension at the PIP joint. Swan neck deformity. Very important as an image-based question, right? The opposite. There will be flexion at PIP and hyperextension at the DIP. So this is your botonier deformity, right? Okay. Now, this is Z deformity. Z deformity. Now, also called as hitchhiker thumb. Can anyone tell me the name of this deformity? So, this deformity is called piano key deformity. Piano key deformity. Fine. So, what is this? This is subluxation of ulna. Subluxation of ulna. Piano key deformity. Very good, Dr. 𝗘𝗍𝗂. Now, investigation. RA factor, what is the problem? RA factor is non-specific. What is specific? Anti-cyclic citrullinated peptide antibodies, right? Treatment, NSAIDs and DMARD, disease-modifying anti-rheumatoid drugs. Now here, I have kept 2-3 mnemonics for your rapid reference, right? So, Eliza, please give her methotrexate. Fine. You see, drug of choice still is methotrexate. And then that's the other mnemonic, MDS aid. That is the mnemonic for DMARDs, disease-modifying anti-rheumatoid drugs. Then these are the mnemonic for associated syndrome. For example, it is associated with Peltier syndrome. The mnemonic is Santa. It is associated with Sjogren syndrome. The mnemonic is dried. So your patient will have dry-eyed, rashes, nephritis, salivary glands and dry mouth. Dry mouth. Fine? Okay. Now, osteoarthritis. You see, rheumatoid arthritis common in 20 to 50-year-old females. Osteoarthritis, 60 to 65-year males. What kind of males? Obese males. Obese males. Now, most common joint affected is hip joint. In India, which is the most common joint affected? Knee joint. Fine? Knee joint. So, joint spared is metacarpophalangeal joint. Now, remember, metacarpophalangeal joint is the most common joint affected in rheumatoid arthritis. Now, two types of arthritis, primary and secondary. So, in primary osteoarthritis, cartilage is destroyed by aging. Secondary osteoarthritis, cartilage is destroyed by infection or intra-articular fracture or rheumatoid arthritis. Clinical feature, pain. Fine. Pain with first step in the morning, and the pain is severe by evening. Pain is severe by evening. So, rheumatoid arthritis pain improves by evening, and here the pain will increase by evening due to wear and tear. Now here, what you see? The swollen, you see the swollen DIP joint, Hepburn node. Swollen PIP joint. So, PIP joints are swollen. That is called as Bouchard node. DIP joints are swollen. That is called as Hepburn node. Fine. And then what kind of deformity is common? Genu varum. So, O forming between the legs. That is called as osteoarthritis. So, that's a way to remember, genu varum. X-ray finding. What is X-ray finding? Asymmetric asymmetrical loss of joint space more on the medial side, right here. You see there is no joint space, and on the lateral side you notice that still some space is present. What is the next thing which you get to see? Osteophytes, right? Let's move forward. Now you see these are the osteophytes. These are osteophytes, right? See, osteophytes here. The osteophytes. See, you see these are the osteophytes. The osteophytes. Gold standard investigation is arthroscopy, where you get to see loose flakes of cartilage, Now, one-liner questions. Most common cause of loose bodies in the joints: osteochondritis dissecans. Most common cause of loose bodies in the joint in elderly: osteoarthritis. Treatment is total joint replacement. Fine. Now, chondroprotective agents like those who are said to protect the cartilage: chondroitin sulfate, fine, and glucosamine. So they offer limited benefit. So next is psoriatic arthritis. Now it is called seronegative arthritis because, why it is called as seronegative arthritis? Because you see RA factor is almost always negative in all the patients. Male-female ratio is equal. Most common age is 30 to 50 years. And the causative agent is HLA-B27, right? Clinical feature: asymmetrical oligoarthritis. If I am your patient, left side wrist joint is involved, it is not necessary that right will also be involved. Okay, so asymmetrical sacroiliitis. Now, what kind of clinical feature? Sausage shaped digits are seen. Sausage shape. Osteolysis leads to telescoping of the digits. See, now here, what do you get to see? These are sausage shaped digits, sausage shaped fingers. Now, if you pull this finger out, it will become long. If you release, it will become small. Fine. So this is telescoping, like a telescope. You pull it, it becomes long. You release it, it becomes small. जैसे वो पुराने कॉर्डलेस फोन में एंटीना होता था, एंटीना खींचो, एंटीना लंबा, एंटीना दबा दो, एंटीना छोटा. That is what happens with the fingers, right? Then you see the skin fold. These skin folds, they are called as opera glass hands. Right? Opera glass hands. So this opera glass, this is an opera glass, right? Pencil cup deformity. So you see here. So this is the cup and this is the pencil. pencil cup deformity, pencil cup deformity, right? Now here we get to see ivory phalanx, ivory phalanx, ivory phalanx. This ivory phalanx is seen in the healing phase. Ivory phalanx. Yes, yes, yes. Ivory phalanx. See here, what happens is, see, this becomes the pencil and this is going to become the cup. Pencil in the cup appearance. देखो जी, ये cup और ये pencil. ये cup और ये pencil. Pencil in the cup appearance. Now treatment, NSAID and multiple other drugs. Fine. Cyclosporin, azathioprine, infliximab. अगर आपको याद करना है, if you need to remember, just remember this. Right? Let's move forward. Ankylosing spondylitis. It is associated with HLA-B27. Fine. Affects the axial skeleton. The disease starts at sacroiliac joint. Sacroiliac joint. Primary site of inflammation is anthesis. Site of attachment of tendon with the bone. जहां tendon आके जुड़ेगा bone के साथ, वो area inflame हो जाएगा. Right? Clinical feature. It affects the male 15 to 25 years of age. 15 to 25 years of age. Extra articular. That means apart from bones, your patient will develop, uveitis, IgA, nephropathy, inflammatory bowel disease, inflammatory bowel disease. Now, New York criteria, you just need to remember the name और कुछ नहीं याद करना है इसमें. New York criteria is used for diagnosis. New York criteria, just the name, nothing else. Now, clinical test. For lumbar spine, you ask the patient to bend, patient will not be able to bend. Patient will not be able to bend. Lumbar spine. Test for sacroiliac joint. Test for sacroiliac joint. Figure of 4 test, which is also known as Faber test. Also known as Faber test. Figure of 4 test for sacroiliac joint. Modified Scober also. Modified Scober also. G. Radiological sign. First radiological sign is haziness and widening around sacroiliac joint. Fine. Then you get to see squaring of vertebrae. Squaring of vertebrae. Squaring of vertebrae. Yes, yes, yes. Now here, what you get to see? Fusion of vertebrae. सारे vertebrae आपस में जुड़ जाएंगे. So this is typically called as bamboo spine. Then calcification of inter and supra spinous ligament. क्या नजर आएगा? Something which is called as dagger sign. See, white line in the middle. Dagger sign. White line in the middle. That is called as dagger sign. Dagger sign. Now, if you see white line on the side, white line on the side, see here, white line on the side. Now, this is called as rail road sign, railroad sign. Now, if you see both white line in the side and white line in the center also, so this is called as trolley track sign, trolley track sign, right? Now here, the description is also there, at which ligament is calcified. So if you see two white line on the side, railroad sign. Single white line in the center, dagger sign. All three white lines, trolley track sign, trolley track sign, right? Treatment, NSAIDs and infliximab, okay? Ankylosing spondylitis done. We move to the next topic. The next topic is tuberculosis. Tuberculosis. Tuberculosis of the bones is called as Pott disease. Tuberculosis of the digits is called as spina ventosa. Tuberculosis of the shoulders is called as 𝗘𝗱𝗶𝗁𝗃𝗃. Tuberculosis of the lungs is called as Koch's disease. The most common type of TB is pulmonary tuberculosis. Second most common is about lymph nodes. Which lymph nodes? 40% lymph nodes of the body are in neck. So cervical lymph node. Which cervical lymph node? Jugulo-digastric. Jugulo-digastric. Third most common is skeletal. Some books mention genitourinary. Some books mention the third most common type is genitourinary, right? Tuberculosis. Now, tuberculosis, what is the most common site? Dorso-lumbar spine. Which aspect? Anterior aspect. Anterior aspect. Remember, dorso-lumbar spine. Posterior aspect is most common site for the tumors. Coming back to tuberculosis, most commonly seen at anterior aspect, and most common pattern is peridiscal, when the bacteria reach by arteries. Second most common pattern is central, when the bacteria reach by veins. Third most common type is anterior, that means subperiosteal. Subperiosteal. Least common is posterior. Fine. Which part? Spinous process. Now, please mark, if they ask you what is the least common site affected by tuberculosis, so please mark facet joint if it is given. If it is given in the options. If it is given in the options, please mark facet joint, right? Okay. Clinical feature, insidious onset. Insidious means gradual onset back pain. Then twist tenderness. Twist tenderness. Coin test. While picking object from the floor, patient does not bend the spine. मरीज के सामने कोई कॉइन गिराओ जमीन पे और उसे बोलो उठा के दे, मरीज अपनी कमर को बिल्कुल भी नहीं झुकाएगा, राइट? नो बेंडिंग एट द स्पाइन. Earliest neurological sign is clonus. Then your patient can develop paraplegia, also called as Pott paraplegia. Two types, early onset, late onset. So you need to remember that early onset has got good prognosis. Late onset has got poor prognosis. Tuberculosis important hai. X-ray, what is the earliest change seen? Loss of curvature of the spine. Loss of curvature of the spine. Calcification of the paraspinal abscess is pathonomic. Pathonomic means confirmatory. Confirmatory. Also, intervertebral disc is destroyed early in tuberculosis. On X-ray, you see two, not simultaneous, simultaneous is not the right word, two consecutive vertebrae are destroyed. Two consecutive vertebrae are destroyed in tuberculosis. आपके एग्जाम में दो वर्टिब्रे इकट्ठे डिस्ट्रॉय हुए दिखें, please take tuberculosis. That is going to be the only question which they can ask, right? Now, the deformity. If one vertebra is destroyed, the deformity is called as knuckle. If two or three vertebra are destroyed, the deformity is called as gibbous. If more than three vertebra are destroyed, the deformity is called as kyphosis. In fact, tuberculosis is the most common cause of angular kyphosis in India. Most common cause of angular kyphosis in India. Right? Treatment ATT, anti-tubercle therapy, surgery if there is more than 50% sensory loss, surgery if there is deformity. Surgery is done if sphincter control is lost. So surgery if there is deformity, if there is more than 50% sensory loss, or if the sphincter control is lost. Now, how to stabilize the spine? All these images are important. So this Milwaukee brace. Milwaukee is a city. Milwaukee is a city in USA. Cities के नाम पे रखे गए इन brace के नाम. For example, in India we have developed an artificial foot called Jaipur foot. Now here, this is a brace to stabilize the spine, Milwaukee brace. Then this is Taylor brace. How to remember Taylor brace? TB, Taylor brace for tuberculosis. Now this one is Boston brace, right? Tuberculosis of the hip. So hip is most common peripheral joint affected by tuberculosis. Earliest site is acetabulum. Earliest sign is acetabulum. Now earliest site in femur. Earliest site in femur. Babcock triangle and epiphysis. End result, fibrous ankylosis, that is the fusion of bones, fibrous ankylosis. Remember, TB, it causes bony Tuberculosis, it causes bony ankylosis in spine and it causes fibrous ankylosis in the peripheral joints. Fibrous ankylosis in the peripheral joint. Basically, Taylor prays Dr. Abdullah ji, it is going to stabilize the spine. अब आप उसको कहीं भी use कर लीजिए. But if there is a fracture, then it can be used only temporarily. Okay. Now, tuberculosis stages. Now, this I believe is important only for NEET PG. बस फटाफट से फिर भी देख लेते हैं. Right. So, in the first stage, there will be lengthening. Second stage, there will be apparent shortening. Third stage, there will be real shortening. And fourth stage, there will be gross shortening. Too much shortening. Too much shortening. Right? Now, on X-ray, what do we get to see? We get to see wandering acetabulum. Wandering acetabulum, right? And in the later stages, what do we get to see? Mortar and pestle appearance. Mortar and pestle appearance. I come from Punjab, तो हमारे यहाँ पे इसको कुंडी सोटा बोलते थे. कुंडी सोटा. So this is mortar and this is pestle. Now here, this is the pestle and this is mortar. Mortar, pestle appearance. Mortar, pestle appearance. Right? You see, this is the pestle. इतनी बड़ी सी कटोरी और बीच में छोटा सा फीमर का हेड. Mortar, pestle appearance. Baker's cyst, it is seen in osteoarthritis. It is seen in the posterior aspect of knee joint. In clinical question, इस चीज का ध्यान रहे that it is seen on extension. It is seen on extension. Bursitis. So, infrapatellar bursitis is called as clergyman knee, right? Pre-patellar bursitis, see like this, is called as housemaid knee. This is how it appears. Pre-patellar. Student's elbow. Student's elbow is olecranon bursitis. Olecranon bursitis. Ischial bursitis is also known as Taylor bottom, is also known as Weaver bottom. Taylor's bunion. Taylor's bunion is seen on lateral aspect. Is seen on lateral aspect. You see here, what exactly is bunion? What exactly is bunion? So bunion is basically hallux valgus, but Taylor's bunion is different. Taylor's bunion is seen on lateral aspect, right? Now, tennis elbow. So you see, tennis elbow is lateral epicondylitis here, where the extensor muscles are attached. Golfer elbow is medial epicondylitis. Medial epicondylitis. Now they ask you the test. So for tennis elbow, The test name is Cozen test. So you need to remember Cozen test, just the name. And if you want to go a little forward, Maudsley test, just the name. Nothing else is important, very honestly. Carpal tunnel is the entrapment of median nerve, Fine. Clinical feature, pain and tingling sensation, in the lateral 2 or 3 fingers, Thumb is a lateral finger, lateral 2 or 3 finger. Patient becomes clumsy. Patient drops the objects, right? Clinical test, Fallen test. What is Fallen test? Palmar flexion. Fallen test, also reverse Fallen test. Treatment, physiotherapy or release of flexor retinaculum, right? Let's move forward. Okay, so tarsal tunnel syndrome, you just need to remember the name. Fine. Posterior tibial nerve. Haglund deformity, you just need to remember this X-ray. So this is associated with plantar fasciitis, Haglund deformity, right? Plantar fasciitis. This is asked as an image-based question. Image-based question की तरह आएगा, right? Then, so if you feel a nodule at the metacarpophalangeal joint, this is your trigger finger. And if you notice flexion deformity, fine. So this is Dupuytren contracture. Here, I have compared both of them. So trigger finger, there will be a nodule felt at metacarpophalangeal joint, and most commonly it affects the ring finger. Treatment is excision of the nodule. Dupuytren contracture is fixed flexion deformity like this, limited to medial. Little finger is medial 2 or 3 fingers, right? Now, 𝗘𝗱𝗏𝗀 disease is the inflammation of APL, abductor pollicis longus, and EPB, extensor pollicis brevis tendon. What is important here? Finkelstein test. Fine. So first one is classical Finkelstein test. Second one is modified Finkelstein test. Name is important. Which test? Finkelstein test, right? Finkelstein test. Now, ganglion cyst, also known as Bible cyst, right? So, it is seen at dorsum of the hand, near wrist joint. Now, again, religion is a very sensitive matter, but why it is called Bible? What is Bible? Bible is a holy book. Now, what was the treatment which people used to do? They'll take a book bang it on the ganglion. किताब ली, not exactly Bible, कोई किताब ली और ganglion पे धड़ाम से दे मारी, ganglion फट गया, patient ठीक, right? That is why it was called Bible cyst. It was called as Bible cyst, right? What is the treatment? Treatment basically is excision. Now, next is javelin thrower elbow, also called as Tommy John injury. मैंने पहले ही लिख के रख लिया, क्योंकि अगर मैं कहूँगा फेंकना, अब फेंकने पे किसी और का नाम ले लिया मैंने तो विवाद हो जाएगा. Javelin thrower elbow. Javelin thrower elbow. Now, what is javelin thrower elbow? Acute injury to ulnar collateral ligament of elbow, right? Javelin thrower elbow. Now, we start with the hip joint. Now, hip joint, first topic, developmental dysplasia of hip. Let's call this DDH, okay? It is the most common congenital developmental disorder, most common congenital orthopedic disorder around the world. In India, what is the most common disorder? Club foot. In India, most common disorder is club foot, right? Now, there are several F. This is seen in firstborn. This is seen if there is family history. This is seen in foot first delivery, that is breech delivery, and it is seen in females. Now see, normal baby hips, they lie in the wide part of uterus. Breech baby hips, they lie in the narrow part of the uterus, okay? That is why it is common in breech delivery. Clinical features: apparent shortening of the limb, then asymmetrical thigh folds. You see here, this side, so right and left side, the folds are different. For example, this fold is not present on the other side. So asymmetrical thigh folds, right? Child will walk on her toes. Toe walking. Paddling gait. Paddling means like a duck. Now, Barlow test. Barlow test means dislocation of the hip is easy. Ortolani, relocation of the hip back is also easy. Basically, hip joint is loose. It is not tightly attached. Classic test is for bilateral DDH. Fine. Galeazzi sign. Make the child lie supine with knees folded, flexed. Fine. So Galeazzi sign. Affected knee lies at lower level. Affected knee lies at lower level. Investigation, less than 6 months. What is the investigation of choice? Ultrasound. More than 6 months. What is the investigation of choice? MRI. MRI better है, और प्रॉब्लम क्या है? MRI के लिए बच्चे को सेडेट करना पड़ेगा, जो हम नहीं कर सकते, सेफ नहीं है. X-ray will show broken Shenton arc. Now, Shenton arc is also broken in neck of femur fracture, dislocation of hip, and also in externally rotated normal hip. So there also Shenton arc is broken, also broken in. Treatment is wide abduction of the hip. कैसे? Apply 2 or 3 diapers. बच्चा अपनी टांगे बंद ही नहीं कर पाएगा. But they don't ask you this in the exam. What do they ask? So 0 to 6 months, what is the investigation of choice? Pavlik harness. 6 to 18 months, what is the investigation of choice? Open reduction. And it has to be followed by bachelor cast. 18 to 36 months, femoral osteotomy. 3 to 6 years, acetabular augmentation. 6 to 10 years, no surgery because there is risk of AVN. More than 10 years, what is the treatment? Total hip replacement, right? Then Perthes disease, spontaneous avascular necrosis means there is no trauma. Slightly common in males, idiopathic. The most common clinical feature is limp and there is no pain. Pain occurs in some patients only, right? Now, most common age, 6 to 10 years, 6 to 10 years. X-ray sign. So, first, crescent sign, then gauge sign. See, this is the crescent visible, gauge sign like this. So, gauge sign, what is gauge sign? V shape defect on the lateral aspect, of femur, Now, this is bite sign, right? You see the head is completely destroyed. Investigation of choice, MRI. Treatment, no treatment because spontaneous revascularization occurs. But if it does not occur, treatment is fenestration. You create multiple holes and new blood vessels will form. If they don't form, then osteotomy. You cut the dead bone. You will have to cut and remove the dead bone yourself, right? Okay. Slipped capital femoral epiphysis. It is the most common disorder of the hip in adolescents. Most common association, hypothyroidism. Clinical feature, pain. You see, there is no pain in Perthes disease in most patients. So, pain is variable. But here, this condition is painful, right? Now, Drummond sign, obligatory external rotation with flexion. Now, this point is important only for NEET PG, I believe. Drummond sign. Now, they ask you that this injury is similar to which Salter-Harris classification? So, it is similar to Salter-Harris classification type 1. In 2024, they asked fracture classification. 25 also they asked classification. So, please do read classifications. At least names you should be aware. डिटेल याद हो ना हो कोई बहुत ज़्यादा फर्क नहीं पड़ता, बट क्लासिफिकेशन के नाम ज़रूर याद होने चाहिए, राइट? Now, radiological sign, Prathovan sign. You draw a line on the neck of femur and you will notice this line will not pass through the head. This line will not pass through the head. 𝗘𝗱𝗏 sign, 𝗘𝗱𝗏 sign. Right, see here. 𝗘𝗱𝗏 sign. This line will not pass through the head. Okay. Dislocation of hip. Most common direction posterior. Now this is common in car dashboard injuries. Car dashboard injuries. Clinical feature fodder, that is flexion, adduction and internal rotation. Internal rotation, fodder, flexion, you see, flexion, internal rotation, and both of the legs are together. Vascular sign of Narath, inability to palpate the femoral artery. Vascular sign of Narath. Right? What is the treatment? Closed reduction. What complications? Sciatic nerve injury and avascular necrosis. Anterior dislocation, common in bike injuries, like this. So clinical feature fiber, flexion, abduction, external rotation, and injury to femoral artery, vein and nerve. Treatment, closed reduction. Central dislocation, common in osteomalacia. Fine. If your patient has osteomalacia and gets trapped like this, central dislocation will occur, and treatment is acetabular repair. Acetabular repair. Okay. Now here, these two fractures, comparison. Hip fracture, first is intertrochanteric fracture, also called as extracapsular fracture, Now this fracture occurs at metaphysis. Intracapsular fracture, this occurs at the neck of femur. Now, most common age for intertrochanteric is 70 to 80, and this occurs with trivial trauma. Trivial means mamuli, insignificant, and this occurs with significant trauma. Treatment is dynamic hip screw, or intramedullary nail. Now, intracapsular treatment we'll read on the next page, but you must remember that extracapsular complication is malunion because the fracture occurs at metaphysis, and intracapsular complication is non-union because there is no periosteum. So M for metaphysis, M for malunion. N for non-union because there is N for no periosteum. Okay. Now, intracapsular, what is the treatment? If the patient is more than 65 years plus he has osteoarthritis, treatment is total hip replacement. 65 years and no osteoarthritis, treatment is hemiarthroplasty. Less than 65 years, no complication. Less than 65 years and no complication. Fine. Now here treatment is open reduction internal fixation. Open reduction internal fixation. Less than 65 year and has avascular necrosis. Fine. So we'll do muscle pedicle flap, that is Mayer operation. Mayer operation. Fine. Now old fracture, less than 65 years, and then there is old fracture. Then you can do McMurray osteotomy or Powell osteotomy if there are no complication, if there are no complications, right? Now here also you must remember the classification systems. So first classification system is Garden. Now it is based on degree of displacement, degree of displacement. And then Powell, it is based on angle of fracture line, angle of fracture line with horizontal, angle of fracture line with horizontal, right? Just the names are important. Okay. Now splint and instrument. So if you see a splint, a long pin like this with ribs and a nut in the middle and a nut in the middle. What is this pin? Austin Moore pin. Austin Moore pin. Now there is another device with the same name, Austin Moore. See, there are two holes. What is the name? The iPad is not charging. Austin Moore. So you see in the name also two holes are there. Austin Moore. So it has got single body and two holes. Now this is Kirshner wire. Kirshner wire. Now Steinman pin. If there is a smooth, thick pin, S for smooth, S for Steinman, that is a Steinman pin. Now if you see ribs, then that is a Denham pin. Denham pin, right? Now here, what is this? Crutchfield tongue. Now Crutchfield tongue, it is used for cervical traction. It is used for cervical traction. All these images are important. Now this is a Thompson prosthesis. Thompson prosthesis. What you see here, there is a single solid body and no holes. Next, you see this is bipolar hip prosthesis. What is the easy way to remember? Separate neck and separate head. Separate neck of femur and separate head of femur. Separate neck, separate head. Bipolar hip prosthesis. Right? Now the different tractions. Now this is Gallo traction, used for femur fracture less than 2 years, what do you notice? That hips, they don't touch the bed. Hips, they don't touch the bed. Now, what is this? Bryant fraction. Again, for the fracture femur, 2 to 10 years of age. Now, these are the traction used in adults, Hamilton-Russell and 90-90 degree traction, buck traction. So, if you see this straight thing, almost straight thing, this is a buck traction image, again used for fracture neck, femur. Bowler-Brown splint. This image is super important, right? Now, this is a Kramer wire splint. Kramer wire splint. Now, this one is an ulnar gutter splint. Can anyone tell me what is the use of ulnar gutter splint? आप में से कोई मुझे बताएगा? चलो, आपका नहीं बताने का मन है. It is used for boxer fracture. Boxer fracture. Boxer fracture, that is 5th metacarpal neck. 5th metacarpal neck fracture. Right? Now, here, this is a repetition. This is practically a repetition. So, this one is stack splint. This one is frog splint. This one is T-point splint. Now, T-point splint is for both swan neck as well as for botonier deformity. Botonier deformity. Fine. Now, this is also turnbuckle splint. Turnbuckle splint. Now, this one is knuckle bender splint, and this is for ulnar nerve injury. This one is cock-up splint for radial nerve injury. Right? Photo याद रखनी है जी बस. Fine. Now, Thomas splint for temporary stabilization of for limb fracture, femur fracture. Hip spica cast. Again, the image is important. Now, this is called as buddy strapping. Hip spica cast, they are used for fracture femur. Again, this is what we have already studied. This one is Boston brace. This one is Milwaukee. This is just a repetition. No? We have already studied these. Now, this one is turnbuckle cast. It is not a splint. It is a cast. So, cast is something which is, covering 360 degree, and splint less than 360 degree coverage. Splint less than 360 degree coverage. So, this is used for scoliosis, and in scoliosis, remember the angle name, Cobb angle, right? Now, so this one is giggly saw, used to cut the bone. Fine. Now, this one is osteotome. This is periosteum elevator. Now, this one is bone nibbler. When you want to cut just small pieces of bone, right? Bone nibbler. Now, this one is bone cutter. and this one is rib cutter, right? So images, बार बार आप देखेंगे, 2-3 बार देखेंगे, ये images याद हो जाएंगे, promise, right? Now, gout. So, deposition of monosodium urate crystals in the joint, right? Now, so here, raised serum urate more than 7 gram per deciliter, and it is even more than 6 milligram per deciliter for women, right? Most common age 30 to 50 years, 30 to 50 years, and it is common in males. What are the triggers? So it is seen in surgical stress, common in alcoholic and meat users. जो लोग नॉन वेजिटेरियंस हैं उनमें थोड़ा सा ज़्यादा कॉमन है. बेसिकली इट इज रिलेटेड टू excess protein, right? Now, most common joint, metatarsophalangeal joint, most common bursa, olecranon bursa. Now, hyperuricemia, that is increased level of uric acid. They are, often present but not always present. Now, when you take the X-rays, they are normal. They may even be normal, absolutely normal. Now, in the chronic stage, the tophi form. Tophi are deposition of the crystals around the joints, right? Tophi. So these are tophi, and that is a mnemonic for anti-gout drugs, right? Now, gout has to be differentiated from pseudo-gout. So here, most common joint is metatarsophalangeal joint. Here, the most common joint is knee joint, right? Now here, the crystals are negative bisfringent. And here the crystals are positive bisfringent. Fine. So pseudo gout, the common joint affected is knee joint. Gout, the common joint affected is metatarsophalangeal joint. And the crystals are needle shaped, whereas the crystals here are rhomboid shaped. Shoulder joint. It is the most common joint to undergo dislocation and recurrent dislocation. Now, what are the stabilizers of the joint? So, supraspinatus. How to check if the supraspinatus is injured or not working properly? Fine. That is empty can test. So, like this, that patient has to empty the cans. If they are Coca-Cola cans, let them flow. But if they are beer cans, तो नीचे glass जरूर रख देना, right? Make sure they don't go, the beer doesn't go waste, right? So supraspinatus. Then for the infraspinatus, what is the name of the test? These: beer hug test, belly press test, lift off test. Lift off test का दूसरा नाम क्या है? जर्बर test, right? Now, subscapularis name of the test is horn blower test, right? Okay. Now, what is the most common type of dislocation? Anterior. Now, please mark antero-inferior. If it is given in the option, please mark antero-inferior. if it is given in the options, because that is a better choice, right? So arm is held in abduction like this, abduction and external rotation. And if you ask the patient to do the opposite, that is adduction and internal rotation, it will be very difficult for the patient to contour his flat. Shoulder will be flattened. Shoulder will be flattened. Then the test. So the first test here is Dugas test. Dugas test, that means inability to touch opposite shoulder, inability to touch opposite shoulder, fine. Then 𝗘𝗱𝗶𝗁𝗱 test, that is increased circumference of the axilla, increase circumference of the axilla. देखो एक्सिला सूजा पड़ा होगा, एक्सिला वुड बी स्वोलन, आप नाप के देखेंगे तो ज्यादा ही आएगा। मान लीजिए मैं आपका मरीज हूं, इधर डिस्लोकेशन हुई, इधर एक्सिला सूजा पड़ा होगा, आप नापोगे बहुत ज्यादा आएगा नाप, इधर देखोगे नाप नॉर्मल आएगा। 𝗘𝗱𝗶 टेस्ट, राइट? सो asymmetrical anterior axillary fold, asymmetrical anterior axillary folds. Then Hamilton ruler test. So ruler means scale. So if you place a flat scale, scale will touch the 2 points, acromion and lateral condyle of humerus at the same time. So scale touches acromion and lateral condyle of humerus at the same time, right? Then treatment is closed reduction, right? So what kind of closed reduction? Cocker's maneuver. देखो Cocker's maneuver. So Cocker maneuver is team. Fine? Team. So team is traction, external rotation, adduction and medialization. Medialization means internal rotation, that is a mnemonic. Then Hippocratic method, that is also another method for reduction. And then Stimson method, also called as Stimson gravity method, okay. We move to the next thing there. 3 साल पहले ये क्वेश्चन पूछा गया था, रेड फ्लैग साइन ऑफ बैक पेन. So red flag sign of back pain. What is the mnemonic? Tuna fish. Red flag sign means something dangerous. कि मरीज की जो बैक पेन है वो सिंपल बैक पेन नहीं है, कोई कारण है अंदर. फाइन. फॉर एग्जाम्पल, इफ देयर इज स्पाइनल trauma, if the pain developed after spinal trauma, unexplained weight loss, that means cachexia, this could be due to tuberculosis or cancer. Neurological symptom, that means your patient has prolapse, disc prolapse. Age over 50, risk of cancer, right? Then if your patient has fever and especially evening rise of fever, this could be due to tuberculosis. IVDU means intravenous drug use. Back pain could be due to osteomyelitis. Remember, most common site of osteomyelitis in adults again is dorsolumbar spine, and it is very common in drug addicts. Fine. Steroid use. Fine. So with steroid use, tuberculosis is very, very common. Immunity goes down and tuberculosis restarts. History of cancer. So this cancer which has moved to spine. Cancer which has moved to spine. Now, cauda equina and conus medullaris. You see here. Spinal cord ends at this point. Now, this is called as conus medullaris. After that, what is left? Few nerves are left, spreading like a fan. This is called as cauda equina. Now, if the injury occurs here, cauda equina syndrome, if the injury occurs here, conus medullaris syndrome. Conus medullaris syndrome. Let us see the difference. Cauda equina syndrome. What are affected? Nerve roots. Nerve roots are affected, and these nerve roots are spread. These nerve roots are spread far and wide. Far and wide. Now, conus medullaris. Thick spinal cord. Conus medullaris is the thick end of spinal cord. Thick end of spinal cord. Now, the deficit. In cauda equina, the lesion is lower motor neuron. Lower motor neuron. So, the paralysis of the muscle is flaccid. Whereas in conus medullaris, it is an upper motor neuron. Upper motor neuron. So here it is symmetrical and mixed type. Paralysis is not flaccid, it could be spastic. So, because it is an upper motor neuron, there are brisk reflexes. Because it is lower motor neurons, the reflexes are reduced. Reflexes are reduced. You don't want to remember all these things? Perfectly okay. Just remember that in conus medullaris, bladder control and bowel control is lost. Fine. And here it is preserved till late. Preserved till late. One point you remember this, and second point you remember that here the effect is unilateral and here the effect is bilateral. Just remember these two differences, and you don't need to remember this entire topic. You don't need to remember this entire topic. Just remember these 2 points, right? Only these 2 points. That in cauda equina it is unilateral, conus medullaris it is bilateral, right? These 2 points just, okay? Now, here I have given you 2 mnemonics to remember which structures have type 1 collagen and which structures have type 2 collagen. Fine. So this again is you have to read there. Why do we have to read this? Because when we read PIVD, prolapse intervertebral disc, what do we notice? That PIVD, annulus fibrosus, is covering nucleus pulposus. Now, nucleus pulposus leaks out. What do we notice? That annular fibrosis contains type 1 collagen and nucleus pulposus contains type 2 collagen. So they can ask you, not in orthopedics but in anatomy, they can ask you which collagen is seen in which type, right? Now, PIVD, prolapsed intervertebral disc. It is commonly seen between 30 to 50 years of age and commonly seen in the males. Now, most common site is L4 to L5, right? Most common symptom, backache, radiating pain, right? Investigation of choice, MRI. Treatment is micro discectomy. Disc once slipped cannot come back. Okay, we'll have to cut it off. Speaking of the knee joint, first, patellar fracture if it is undisplaced. Undisplaced means both fragments are close to each other. Both fragments are close to each other. What is the treatment? Treatment is tube cast, also known as cylinder cast. Also known as cylinder cast. Make sure you don't confuse this with patellar tendon bearing cast. Patellar tendon bearing cast. See, patellar cast is up to this. Sorry, tube cast is up to this. Now, beyond this, if you include this, this becomes patellar tendon bearing cast, and this is used for tibia fracture. Tibia fracture. Now, they are also used for tibia fracture. Long leg cast is used for tibia fracture. Cylinder cast, it is used for patella fracture. Patella fracture, right? Now, patella fracture, if it is displaced, what is the treatment? Tension band wiring. If it is comminuted, then what you can do? Partial or total patellectomy. Partial or total patellectomy. Now, this is normal position of patella. If it is below the femur, this is called patella baja. So, B for below. Fine. If it is above the joint, it is called as alta. A for above, A for alta. Right? Collateral ligament injury. They ask you a question, collateral ligament injury is more common on which side? It is more common on medial side. More common on medial side, here, like this. Somebody falls on your patient. Leg of the patient will go outside. That means it is due to valgus force. Valgus force. Collateral ligament which are present on the side. 4 collateral ligament? नहीं भाई जी, 2 ही होते हैं, मैंने तो 2 ही देखे हैं, देख लो. एक मीडियल, एक लेटरल. हाँ, दोनों टांगों के मिला के 4 हो गए. Both the legs if you include, then there are 4 collateral ligaments. Right? Now, ACL injury, anterior cruciate ligament injury, it is common in female athletes because of the way they run, because of the way they fall. Right? Anterior, posterior, lateral, medial. You know, you can call those as cruciate ligament. Collateral means covering all around. Okay. Coming to the ACL, what is the most common site of tear? Mid substance. Fine. Clinical feature, this word is important. There will be immediate pain. There will be immediate pain and swelling. The swelling is due to hemarthrosis. Hemarthrosis. Hemarthrosis means collection of blood in the joint. So the first, second, third and fourth test. Fine. So the first test is anterior drawer test. Now this is done in 90-degree flexion. The second test is Lachman test. So this is done in 20 to 30-degree flexion. Lachman test. You see, the word in Lachman is this. AC. AC means acute. Lachman. Acute. Fine. So this test can be done in acute injuries. Can be done in acute injuries. Third test is pivot shift. Pivot shift. And fourth is Liley test, also called as lever sign. Just remember this Lachman test, right? Investigation of choice will be MRI. Treatment is patellar tendon graft. Patellar tendon graft, right? PCL injury, it is common in car dashboard. Posterior cruciate ligament injury, common in car dashboard. Now, hyperextension can cause both ACL as well as PCL injury. Both ACL as well as PCL injury. Now, what are the tests? Posterior drawer test, Godfrey test. Godfrey test, which will show you sag sign, right? Now, meniscus injury. Most commonly, it affects the medial meniscus. Why? Because it is fixed to the capsule. It has more surface area because it has got O-shaped body and it has got thin body. That means it is comparatively weak. Now, the investigation, McMurray test. The second, apply grinding test. Just remember this. Investigation of choice, MRI. Fine. MRI. Gold standard, arthroscopy. Now, treatment, outer part is vascular, so we will do the repair. Inner part is avascular, so we will do the excision. Right? That was about the meniscus. Now, about the tumors. Less than 40 years of age, what kind of tumors are common? Benign. More than 40 years of age, what kind of tumor are common? Malignant. Now, most common malignant bone tumor, secondary cancer from other organs. Now, why did I attach this? In Canada, if there is any problem, if there is any trouble, local Canadian guy will not be responsible. Canada is full of Punjabis. Fine. So every time there is a trouble, Punjabi would be involved. Right? Now, कोई पंजाबी इस गल दा गुस्सा ना करे वीर. I am also from Punjab, Pakistan border, डेरा बाबा नानक लागे पिंड है मेरा तारागढ़. Right? So please don't mind. लोग गुस्सा बड़ी छेती कर जाते आजकल. This is just a way to explain. Right? So secondary cancer from other organ. Okay. Now, most commonly they come from prostate, and in female they come from breast. Okay. Now, secondary tumors are 50 to 100 times more common than primary bone tumor. बोन में अपना कैंसर नहीं होता, जब भी कैंसर होगा कहीं ना कहीं बाहर से आएगा. बोन के अपने टिश्यू का कैंसर बहुत ज्यादा रेयर है. मोस्ट कॉमन प्राइमरी मैलिग्नेंट बोन ट्यूमर is multiple myeloma. Most common primary malignant bone tumor of osteogenic origin. Most common primary malignant bone tumor of osteogenic origin is osteosarcoma. Most common benign bone tumor is osteochondroma. Fine. Most common benign true bone tumor is osteoid osteoma, osteoid osteoma, one-liners, right? Now, osteochondroma, it's not a true bone tumor because at skeletal maturity, the growth stops, right? Now, most common site, so it is present near the femur metaphysis, distal femur metaphysis. That means around the knee joint. Fine. Now, treatment is extraperitoneal excision if symptomatic. कैसे symptomatic होगा? You know what happens is it compresses bursa or a nerve, right? Enchondroma, most common benign tumor of hand bone. Most common site, phalanges. Fine. So this is the typical X-ray. This is the typical X-ray. Now it looks like spina ventosa, that is tuberculosis of the fingers. Tuberculosis of the fingers. So multiple enchondromas are seen in two diseases, Ollier disease and Maffucci syndrome. Maffucci syndrome. ये जो word है N means inside. N means inside. Yes, 110%. Osteoma, ध्यान दीजिए ये osteoma है, osteoid osteoma नहीं है. Fine. So what are the osteoma? सिर्फ क्या है? That किसी एक जगह से skull bone बस थोड़ी सी बड़ी हो रखी. At one point, the skull bone has enlarged a little bit. That is called as osteoma. Right? Now, clinical feature. Cosmetic deformity or sinusitis if it blocks a sinus. मैं सबसे रिक्वेस्ट करता हूं ये वाला वीडियो मेरे को दिखा के मेरे को भेजना फोटो इसकी. अगर इस वीडियो के बाहर कोई भी क्वेश्चन आ गया एफएमजी में ऑर्थोपेडिक्स का, फाइन, ये वीडियो मेरे मुंह पे मारना वापस आके. सारे क्वेश्चन इसी में से आएंगे. सारी ऑर्थोपेडिक्स हमने पढ़ डाली, बचा क्या बीच में पीछे एक क्लब फुट बचा शायद, राइट? उसको भी मैं जब पीडीएफ दूंगा वो साथ में लिख के दूंगा. 100% सारे क्वेश्चन इसी में से आएंगे. पिछली बार भी कहा था, पिछली बार भी सारे उसी में से आए. देख लो पिछली बार का वीडियो. ऑस्टियोइड ऑस्टियोमा, ऑस्टियोइड ऑस्टियोमा, तो ये रहा ऑस्टियोब्लास्ट फादर, राइट? नाउ ये उसका पहला बेटा, ये दूसरा बेटा, तीसरा बेटा, चौथा बेटा, राइट? So from osteoblast, 4 tumors appear. Osteoma, osteoid osteoma, osteoblastoma और लास्ट में osteosarcoma, osteosarcoma, राइट, osteosarcoma। तो ये रहा ऑस्टियोब्लास्ट और उसमें से सारे ट्यूमर निकल रहे, ऑस्टियोइड ऑस्टियोमा, ऑस्टियोब्लास्टोमा एंड osteosarcoma, right? Now, osteoid osteoma, it is the most common benign true bone tumor, fine. Now, it is not because of NSAIDs, but the problem is that the tumor secretes prostaglandins, right? So that is why it is painful. Most common location, femur and tibia diaphysis, Now, pain relief with NSAIDs, non-steroidal anti-inflammatory drugs. What is important? Important here is this image. So, if you see dark center, white periphery. So, you see here white periphery and dark center. And if you see at the junction of metaphysis and diaphysis, 110% it is osteoid osteoma only, fine, osteoid osteoma only. तो आप कह रहे हैं ना ब्रोडीज एब्सेस इज सीन एट मेटाफाइसिस, उसमें भी डार्क सेंटर होगा, वाइट पेरिफेरी होगी, लेकिन वो कहाँ होगा? मेटाफाइसिस पे। बट अगर आपने डायाफाइसिस और मेटाफाइसिस के जंक्शन के आसपास देखी ऐसी चीज कि अंदर काली है ऊपर से सफेद है, देन इट इज ऑस्टियोइड ऑस्टियोमा ओनली, बट वो मेटाफाइसिस पे होगा। पेन रिलीफ विद NSAID. नाउ हेयर osteoid osteoma. Now, osteoid osteoma is perfectly benign. Osteoblastoma is benign but little aggressive. And osteosarcoma तो है ही malignant. This is malignant. Now, that is a way to remember this tumor. Osteoid osteoma less than 2 centimeter, osteoblastoma more than 2. Location, femur and tibia diaphysis, osteoblastoma, spine. Neoplastic behavior, benign plus aggressive growth, fine. Now, relief with NSAIDs is good because this tumor secretes prostaglandins, and here there are no prostaglandins. Now, here central nidus, that means center is black on X-ray, and here center is white on X-ray, right? Okay, osteoclastoma, favorite tumor of examiner, 20 to 40 years old, seen in females. It is seen at epiphysis. देखो, ये रहा diaphysis, ये रहा metaphysis. Tumor is seen at epiphysis, and it is not seen in the center. It is seen at the periphery. That means eccentric. It is expansile. That means it rapidly expands. And it makes the bone very, very thin. So thin that it is called as eggshell crackling. और पांचवा E, N block resection. N block resection is the treatment. En bloc resection is the treatment, right? Unicameral bone cyst, also called as simple bone cyst. It is seen between 4 to 10 years of age. The most common location, metaphysis of humerus. Metaphysis of humerus. And what are the causes? Brodie's abscess is an osteomyelitis caused by Staph aureus. Liquefied enchondroma, it will give rise to cyst. Hemophilia, it will also give rise to cyst. Now, X-ray, yes. X-ray is, it will give rise to fallen leaf sign. Fallen leaf sign. Fallen leaf sign. Fallen leaf sign, also called as trap door sign. Trap door sign or fallen leaf sign. Aneurysmal bone cyst. USP6 mutation. Now, what do we get to see on the X-ray? We get to see finger in the glove. तो देखिए डॉक्टर साहब लोग जी, ये तो रही फिंगर और ये रहा ग्लव, सॉरी balloon. Finger in the balloon sign. Finger in the balloon sign. Finger in the balloon sign is seen in aneurysmal bone cyst. What is the problem? USP6 mutation. So instead of bone, what is present? Blood. Why? Because if this mutation occurs, there is increased production of matrix metalloprotease, and this enzyme, it destroys the bone. It destroys the bone. Treatment is excision or cautery with nitrogen. Cautery with nitrogen, right? Osteosarcoma. Now, it is the most common primary malignant bone tumor of non-hematopoietic. That means it arises from hard bone. It is the most common malignant bone tumor in children. Most common radio-resistant bone tumor, because it is most common radiation-induced bone ट्यूमर. तो जो बना ही रेडिएशन से है, रेडिएशन क्या मार लेगी उसको, राइट? मोस्ट कॉमन साइट इज फीमर metaphysis. If it is radiation induced bone tumor, skull is the most common site. Skull is the most common site. So yes, this is the most common age, 15 to 20 years. So two types, primary. 75% cases are primary. It is seen at 15 to 20 years of age. Now, secondary due to Paget disease, radiation exposure or osteomyelitis. It is seen at 50 to 60 years of age. Now, it is a bone forming bone tumor. So, periosteum will be lifted above and it will give rise to sunburst appearance. Give rise to sunburst appearance. Give rise to sunburst appearance. Right? Sunburst appearance. Now, make sure this. So, sunburst appearance and sunburst trabeculation, they are different. Sunburst trabeculation, they are seen in benign tumor. And sunburst appearance, It is seen in osteosarcoma. It is seen in osteosarcoma. So, sunburst appearance is seen in osteosarcoma, and sunburst tuberculation, they are seen in hemangioma. They are seen in hemangioma, right? Make no mistake. Now, in aggressive tumor, what do we get to see? We get to see Codman triangle. We get to see Codman triangle. The Codman triangle is seen in aggressive tumor. Now, it may spread by blood to lungs. Management is chemotherapy, and after that we will do surgery. After that we will do surgery. Now, why chemotherapy? Why chemotherapy first? Because most of the tumors are metastatic. Because most of the tumors are metastatic. Most of the tumors are metastatic. Where? To the lungs. So we will have to do chemotherapy first. Fine. Ewing sarcoma, most common tumor of multicentric origin. Most common age 5 to 15 years. Site femur diaphysis and pelvis. Clinical feature pain, swelling and fever. That means same as osteomyelitis. Same as osteomyelitis, but in osteomyelitis, what is the site? Site is metaphysis, and here the site is diaphysis. Here the site is diaphysis. Now, X-ray will show onion peel appearance, multiple layers. Onion peel appearance. See, onion peel, multiple layers, right? Biopsy will show pseudo-roseates. Biopsy will show pseudo-roseates, right? Treatment is chemotherapy followed by surgery. Keep in mind this tumor is radiosensitive, but because the patient are small children, we do not do radiotherapy, right? Multiple myeloma. It arises from red bone marrow, and most common age is 50 to 70 year in males. Most common site lumbar vertebrae. Systemic clinical feature fatigue, fine, anemia, weight loss. Short duration disease because it kills your patient. X-rays will show you punched out lytic lesions, which is called as rain drop skull. Now, this is also a common doubt in the minds of the student, that what is the difference. See, the treatment is melphalan and bortezomib. A common doubt is there in the mind of the student, that what is the difference between raindrop skull and salt pepper skull. So you see, salt is white and pepper is black. In hyperparathyroidism, there is excess of calcium. excess of calcium drawn from the bone. So that area from where the calcium is withdrawn, lytic area, that appears black like pepper. And where the calcium is deposited, that area appears white like salt. You see here the white area. W means white area, dark, bright white area. This is salt and pepper skull. Whereas on the other side, there are no bright white areas, only black areas. That is raindrop skull, right? Okay, so that is all which I had to offer to you guys, right? Please do read this. I will share the PDF as soon as possible. I will share the time stamps. See, in club foot, just give me a minute. Club foot, what do they ask? It is bilateral, right? Club foot, bilateral. It affects the first born males, is idiopathic, is commonly associated with neural tube defects. What is the anomaly? Cavus, adductus, fine, equinus and varus. Okay. Now, how do you make the diagnosis? Ultrasound at 24 weeks of pregnancy, right? Okay. At birth, inability to approximate, right? X-ray, what do you get to see? Kite's angle. Kite angle is between talus and calcaneum. Treatment, Ponseti method. Ponseti method, first correct cavus, then correct adductus and varus together, and in last correct equinus by serial casting. That's one thing, right? Then if the patient comes to you, between 1 to 4 years of age, posteromedial soft tissue release, right? 4 to 8 years of age, osteotomy like Ivan Delvin. 8 to 10 years of age, wedge tarsectomy. And more than 10 years of age, triple arthrodesis, TNTCCC, talonavicular, talocalcaneal and calcaneocuboid, right? Now, if the correct order is not followed, your patient will develop rocker bottom foot. Your patient will develop rocker bottom foot, right? Only these things they ask in club foot, fine. Second, they ask about the Dennis Brown splint, okay? That's the only thing which they ask in club foot, okay? Thank you. Thank you so much and wish you all the best.